Good morning.
Hello, good morning.
Okay. Thank you so much for making time with us today. My name is Justice Novenyo. I lead the Health Economics Program at the Africa Centers for Disease Control and Prevention, which is based in Addis Ababa. And I'm here on behalf of the tripartite that is co-organizing this pre-conference workshop. So that includes the Africa Health Economics and Policy Association, with its executive director as John Taguba, who stands right here, and the African HTA Network, which is housed at Kemri Wellcome Trust, based in Kenya. So we know that UHC has become a topical issue, not only framed at a global level, but at each country across the globe is planning and striving to expand critical healthcare services coverage. And that also includes, health promotion services to their populations. But as economists or people who have interest in economics, I assume that you're either economist or you have an interest to have been at an AHIA conference. My first AHIA conference was 15 years ago as a master's student, and I've been at every single conference since then. Our interest is not simply providing those services to people, but how to provide these services in a way that does not systematically leave out sections of the population. And I'm talking about equity, how to provide high quality services, all within the context of limited resources. And so for us as economists, one of the critical contributions we make to decisions around who to provide services, what services to provide, who to provide services for, and all of that within the context of constrained resources, is to inject approaches that will help decision makers, make these decisions efficiently and equitably. So evidence-informed priority setting is key for us. And health technology assessment is one tool that helps us to achieve that goal. We know that HTA has caught up with the rest of the world, but the environment for HTA and evidence-informed priority setting in Africa is growing, and the grounds are fertile. Many of our countries have put in place mechanisms to do that. We can only support and promote this, not only in Africa, but work with others across the world. And we are pleased that you are here today to share with us your precious time as we go through this workshop. The purpose of this workshop is, as the name implies, an introduction. And for us, the tripartite, the Africa CDC, AFIA, and Kemri, this is one of many such that we'll come up with, all in a way to harmonize, not harmonize, but to strengthen capacity across the place for the use of evidence-informed priority setting processes such as health technology assessments. So I wish to thank you for giving us your precious time. And just so you know that the day is going to be full of introductions, because we do have, beyond the conference, plans to extend this kind of engagement. So with that said, let me invite my colleague, John, the Executive Director of AFIA, to welcome you all on behalf of the tripartite. Thank you. John.
Good morning, everyone. Thank you very much, Justice, for that warm introduction. I'm John Ataguba. I'll give you a bit of story about myself. If you recall, when we wanted to host a year in Cape Town about long time ago, 5 years ago or thereabout. We welcomed everyone to Cape Town, then COVID hit, and we were unable to host people in Cape Town. Now, fast forward, we now had the virtual HTA Congress, and then here we are in Cape Town to host the HTA Congress. And between the period when we welcome people to HTA in Cape Town and now, I did welcome people, but unfortunately, I'm no longer based in Cape Town. I used to be based in Cape Town, but no longer based in Cape Town. So that's why a lot of things happened in between. So I am John Ataguba. I am the Executive Director of the African Health Economics and Policy Association, which is acronymed AFIA. In my daytime job, I hold a Canada Research Chair in Health Economics at the University of Manitoba in Canada. So it's a pleasure to have you here. We have a series of activities planned out. This is one of them. The next is happening tomorrow. For those who've registered, this is an introduction to health technology assessment. Justice has introduced this clearly. We hope that by the time you're through with this, you have pretty much like a flavor of health technology assessment and how you can apply them within your settings. Though we're looking at this mainly with the eye of Africans, but there is nothing that limits whatever we're going to discuss to Africa. It's pretty much a global agenda. I would want you to also know that AFIA is an association just like HTA that welcomes members. So if you want to become a member of AFIA, we are open for registration. You can see we have a banner there. Africa CDC also has a banner by the side there, so you could take a look. And if you want to become a member, there's a QR code there. You can scan the QR code, takes you straight up to the site where you can register, and we will be happy to have you as a member. You don't necessarily need to be an African to be a member. All you need to do is have the African spirit. And if you understand what that means, we are all Africans. So if you have the African spirit, then become a member of AFIA. So I want you to have a fruitful, we got a series of well-trained experts who would take you through today. I will be facilitating the session tomorrow on equity. If you signed up for that, you'll see me again facilitating the session on equity tomorrow. So I don't have much to say, but to hand over the floor to Jacob, who will take it up from here. Thank you very much.
So, good morning, everyone. Okay, I don't sound that loud, but I don't know why. So I'm Jacob Kazungu. I work at Kemri Wellcome Trust Research Program in Kenya in the Health Economics Research Unit. And I'm just going to set the background today for the rest of the presenters. So I'm just going to talk about an introduction to priority setting and how that links to strategic health purchasing and universal health coverage. So I hope by the end of this presentation, we'll have appreciated what universal health coverage is. We'll have appreciated the link between health financing functions and universal health coverage, as well as the link between purchasing, strategic purchasing for that matter, as a health financing function, and the critical decisions about what to purchase and why we need to priority set. So universal health coverage, I mean, we can make this as interactive as possible. UHC is the buzzword that all of us have heard about it. So what is UHC? It's a workshop, so it's not just about me. So what is UHC in your own understanding? What is this 3.8? Okay, exactly what you're thinking. So we know universal health coverage is a global health priority. And, sorry, I have to move in between two things. Essentially, it's the target 3.8, where we aim to achieve universal health coverage, and all global leaders have aimed to make this one of the #1 priority. But what does it mean? So when we talk about universal health coverage, it's about three key things, okay? Making sure that the population can access, all the services that they need whenever they need them. Those services are of good quality and effective, as well as when people access those services, they are protected from experiencing financial hardship, okay? So when we talk about UHC, there are these three key dimensions that we always refer to. So when we want a country to make progress towards achieving universal health coverage, they must expand, the set of services that they are providing on behalf of the population. They must also cover more people. So ensure that there's quite a good or even 100% population coverage, but also the population is protected from experiencing financial hardship. So reduce mostly the out-of-pocket expenditure at the point of accessing care. So this can be looked into these UHC goals. So one is making sure there's equity in use of healthcare services, and John will cover this more tomorrow. But essentially, removing all those bottlenecks that prevent people from accessing care, while the top people have it easy to access the health facility, it appears to be problematic, especially to the lower level population. So removing those bottlenecks, but also making sure that the quality, the care, the services that are provided are of good quality. Imagine you've just gone to, to the doctor, you've had your surgery that you wanted to do for a very long time after waiting, and then the doctor is telling you, I have good news and bad news, okay? So perhaps the good news is the surgery went well, but the bad news is we left something in your head and you won't remember that what I've just told you. That care is not of good quality. And then the third aspect is making sure that people are protected from, experiencing financial hardship. So again, we don't want a healthcare system where they're not removing real lumps in your body, but rather your pockets are emptied. So we want a healthcare system that is affordable, people can afford, and they don't have to suffer from financial hardship as a result. So how does this all fit within the healthcare system, and especially health financing? We all know of these 6 building blocks of the health system. When we talk about the health system, we characterize it across these 6 main dimensions. So there must be good leadership and governance. Of course, healthcare financing, there must be funds to fund the whole health system. There's health workforce, medical products and technologies, information and research, but also service delivery. So at the center of all those, so we can't have all these other dimensions or building blocks without funding. So financing for healthcare is very central. So when we talk about health financing and health financing functions, as a healthcare system, there are 3 key decisions or functions that are related to healthcare financing. So one, for any good health financing system, it must be able to raise revenue, okay? So we say there must be money to fund everything, but where does this money come from? So there must be ways to be able to raise revenue and then pull together all those resources, sort of to accumulate them together, whether it's in a sort of an insurance body or insurance scheme or whatever that accumulates the resources and then transfers them to healthcare providers to buy the services on behalf of the population, what we are calling purchasing. So we'll talk more about the third key function in this discussion. So looking at health financing and UHC goals, we have the three health purchasing decision: revenue collection, pooling, and purchasing. And, you know, they directly or indirectly link to both the intermediate goals as well as the UHC goals, as you can see. So just to take a deeper dive onto healthcare purchasing. So we've said that purchasing is a key health financing function. So what is it? Essentially, purchasing is the transfer or allocation of funds to the healthcare providers to obtain the set of services that are entitled to an identified, group or identified population within a country. And this is what happens. So one, we have always the collection of funds. So individuals contribute to the pooling organization or purchasing organization through whatever mechanism. So whether they pay taxes, whether they contribute through contributory mechanism, whether mandatory or voluntary, but all those funds are accumulated and collected to a purchasing or pooling organization. And then that organization transfers those funds to health facilities, what we are calling healthcare purchasing, to pay for the services on behalf of the population, while the population obtains healthcare services from the facilities, okay? So that's sort of that link between transfer of funds from the purchasing or pooling organization to healthcare purchasing is to the facilities is what we are calling healthcare purchasing. And it provides the critical link between the resources that are mobilized for universal health coverage and the effective delivery of healthcare services. So within the purchasing function, there are three key decisions that purchasers or policymakers need to make. And one of the key decisions is, you need to make a decision around what do you want to buy, okay? What is this set of healthcare services that you want to buy on behalf of the population that you want to buy for? And then that's not all. You also need to make a decision around who are these healthcare providers you're going to engage to provide the services on behalf of your population. That's the second decision. And then thirdly, there's the decision around how to buy. So what contractual arrangements are you going to enter with the healthcare providers? What provider payment mechanism are you going to use to reimburse healthcare providers? And all the decisions around that. And today we're going to talk mostly around what to buy because it's the first key decision. And, as we'll talk about it in a bit, we can't buy all the services at this point in time. We must make decisions around, based on our budget, what are the things that we are going to include at this time? What are the things we are not going to include? How much does it cost? What is the need? And all those decisions. So why we need priority setting, essentially. Okay, so again, we know our countries and we are coming from, most of us, low and middle income countries, but also even the high income countries. Countries do not have all the money to spend in healthcare, They also need to spend in agriculture, in other sectors, defense, etc. So we're working in a space where we have limited resources. And for us to utilize those limited resources in the best way, then we need to identify what set of services to purchase and what not to purchase. And that brings, the notion of we need not just spend, but we need to spend strategically, okay? So we need to move from what we are calling passive purchasing to a situation where we are purchasing strategically. So passive purchasing here implies, you're just buying because so if I come to you, you owe me money. I hope you are. And then I just tell you, you should have paid me $1,000, but you don't really ask me, okay, but what service did you give me for me to owe you $1,000? So you're just paying money because you presented bills. You're paying money because last year you paid something similar. You're just paying money to a situation where, we are continuously searching for the best mix of ways to maximize health system performance by deciding what are those interventions you're going to buy, how are you going to buy them, and from whom you are going to buy them. So instead of just paying, you're looking at, so if we are, as a healthcare system, if we were to, for example, do task shifting as one of the areas, how would that perhaps produce better outcome or same outcome with the least cost, or, even more outcomes with an additional cost. So you're looking at what are the best mix of services to buy and the best way to do them. So you're not just saying, for example, you're going to contract only public providers. Perhaps introducing private providers into the mix would make it more cost effective or more will increase access to care. So you're making decisions based on evidence, and it's a continuous process. So it's not because you made the decision today, it's cast on stone. No, so you're continuously, periodically reviewing and making those decisions. So purchasing arrangements are strategic when they are structured to optimize equity, efficiency, and the quality of care. Yeah, so again, I said, while all countries need to extend population coverage, make sure that they extend the range of services provided and reduce out-of-pocket expenditures, we have limited resources. And as decision makers, when you're faced with limited resources, I'm sure all of us somehow earn something, and we always have desires and wants, and we can't buy all of those at one point in time. So we, in some way, every day, priority set in our own setting. So in our own way, we always do priority setting. You choose to buy what you can buy at that point in time. You choose to go where you can go, whether it's a vacation or what, based on, your current situation. And therefore, this is what also decision makers in the health space also have to do. So they priority set, they prioritize by selecting the range of services that can be purchased at that point in time. And this brings the discussion around the need to develop a benefit package, okay? Yeah, so essentially, a benefit package is a set of publicly funded entitlements for the defined population group, and also not just the service entitlements, but also has the set of conditions for access to those services. So for example, we can say within the range of services we are providing, you will also get, let's say, a certain surgery. But for you to get that surgery, you have to wait for 2 months, 3 months, 4 months, or something like that. So that kind of also introduces a condition for you to access the service. But the most important thing here is that, the decisions and those policies that are related to benefit package are more than just producing the list of health service entitlements for the population. So when these decisions are aligned, then are aligned with health financing and other functions, then the benefit decisions are the way policymakers steer the health system towards universal health coverage. So there's a direct link between benefit package design and the overall health system objective. So we always aim for a health system that has equitable use of services, access to services, financial risk protection, it's transparent, and we aim for efficiency. So how that links with the benefit package design So benefit package design ensures equitable use of resources, for example, because you harmonize the benefits entitlements for the population. You ensure you're including and addressing demand side barriers for the population. So you are targeting services perhaps based on need of the population or cost, but essentially you're harmonizing the benefit entitlements. The second is financial risk protection or financial protection. So there's a public fund cover when you design, and this is not just benefit package for an insurance, but it could be an essential medicine list within the country. It could be a set of services provided publicly by the government, not necessarily by a health insurance body. And then when people understand the process of how services were included or excluded, that gains trust and transparency with the body. So people will clearly understand, you know, we have been given these services because this process was followed. This is why this service was included and these were excluded. So there's some transparency in there. And of course, as you are including services, perhaps you're also looking at what are those most cost-effective services or the best mix of healthcare services that you can include. So that also enhances efficiency. Yeah. So the big question is, we've been talking about, you know, all these links and, you know, essentially pointing to why we need to have a process that will guide how best we select what services to include and what services not to include. So the big question is, how should we make these decisions about what to purchase? What process should we follow? Okay. The short answer to that is priority setting. And the long answer to that, I don't have because my colleague will provide. So thank you very much. Yeah, so I'll open the floor to some questions and answers, but I also know you already have the answers. So anyway, welcome. Any questions, comments, answers?
Thank you for your nice presentation. Just for, I have this only one question. Is that, can we calculate the USC index to assess the USC performance by a particular country? In terms of the healthcare resource use, you know, it's the different country, they also try to introduce the different type of program. In terms of the assessment, can we calculate the USC index? Then we can also look at the which type of the country will achieve the universal health coverage.
To get your question, can we calculate the UHC index and use it to determine the set of services to include? Okay. Any other question?
Thank you. My name is Eva. I'm from Indonesia. I'd like to ask your experience in developing strategic purchasing for HIV services. I know that this can be different depending on different health systems. I'm just wondering whether you or our colleagues here have experience in developing or implementing them. Thank you.
Okay. So I know we are all experts in the room, so I'll start with hers and I will deflect it back to the room. I don't work in the HIV area. Anyone in the field? before I give my 2 cents? Come on. Okay, no one working in HIV? Not necessarily strategic purchasing, but HIV? Okay, so I'll just give sort of my view on strategic purchasing and specific services. So for strategic purchasing, what we've changed is we're looking for evidence to determine what to buy, from whom to buy, and how to buy. Okay, so looking at HIV services specifically, or so for instance, it would be what would be the most efficient way to provide HIV services. So if it's, for example, testing and I don't want to call it treatment, but people taking ARVs. So who perhaps would be the best person to provide those set of services if you have to make those decisions? And then how do you pay for them? Okay. Would you pay for HIV services under, for example, a capitation model where everyone who is HIV positive is capitated to a certain facility where they get the services? Or are you going, so making those decisions. I might not be very well versed within the specific area, but anyone else would like to comment on strategic purchasing and any other service on their area?
So hello everyone, I'm Sharon from Zimbabwe. I don't necessarily work in HIV, but I've done work on HIV. For example, I've done a gender assessment on the HIV response in Zimbabwe. So I would want to maybe put strategic purchasing in to link it with what I've done. So you would find that some of the things that we found is in terms of gender, some people are affected more in terms of the services that are provided by the government. So when you do this gender assessment, then you see that access is restricted in other population groups. I would like to believe it informs the policymakers now that how can we improve this access and how can we devote funding so that it reaches to what population is deprived of access. So it would speak to the effect of what services should we produce and who to purchase for, and then whom to purchase from. So that was just a context of an example of strategic purchasing in HIV.
Thank you. And then to your question around, can we use the UHC index to determine what set of services to include within a health benefit package? So the general answer that I have is it depends with the context. So when you're determining what set of services to include, the country has some set of criteria that they use to determine, what are those services that are going to be included. So the UHC index could be one of the criteria, or it could not, based on the set criteria that a country has chosen to use to determine what services to include or not include. But my colleagues will talk more about, what are those criteria that you could consider in the next sessions. Yeah.
Hello, thank you for the presentation. I'm Ashuru from Nigeria. I think it's quite informative setting this background. And I think for me, the key reflection I had was the last slide, trying to link the health benefit package with the health system's objectives. And one of the things I come to realize as you're presenting is while governments can pull up together some set of services and say, okay, these are our health benefit packages, but they're like in most of the circumstances, you realize that the demand side barriers are not addressed. And so even though the services are there, people still do struggle to get access to quality services. And additionally, even for those that they were able to get, so the financial protection is provided, but you realize that people really don't know the depth of these packages. So the transparency is usually affected, and so also the efficiency. So I think perhaps the key takeaway for me is, I mean, it's not a one size fits all. You don't just say, oh, we have these services, go and get them, but you equally need to look within the system's context to address a lot of things, including the information and what have you, for people to have access to quality and then to reduce the out-of-pocket expenditure. Thank you so much.
Thank you very much. Any other last burning question, comment? From the online team, okay.
Hi there, I'm Caroline Watts from the University UNSW, from the Kirby Institute in Australia. Someone just mentioned out-of-pocket costs, and I guess we'll talk about that later, but I guess that's the other side of it, isn't it, really? Is if you've got universal healthcare, then what's the other part? What are people going to pay as well? Because I guess you can't assume everything will be paid for. Just a comment rather than a question, but...
Yeah, I think we will also talk more about it.
Okay, mine is just a comment. My name is Melvin. I'm from Cambry Wellcome Trust research program. I just wanted to add a comment on the question on whether you can use the UHC service coverage index to determine which health services should be prioritized. I think the coverage index is more of a measure of coverage in itself, and it has inputs and was calculated by Wagstaff a few years ago. They had a set of, to calculate the service coverage index, the target was 80% service coverage and 100% financial risk protection. With financial risk protection looking at catastrophic health expenditure, and the service coverage index calculated as geometric mean of 8 health services. So pretty much antenatal care visits, full immunization, breast cancer, cervical cancer screening, skilled birth attendance, treatment for acute respiratory infection, treatment for diarrhea, and inpatient admissions. So pretty much having weight for each and every health service. So it's a good measure of coverage and the intended target, but is it a good metric for deciding which health interventions to prioritize? I think, for my opinion, no, that prioritization has to happen before. So that is just a measure of whether you're going to achieve UHC or not. So there are different methods on determining which health services should be prioritized. You have deliberative processes and so on, including criteria and such things. Yeah. So I said, so yeah, that's my take on that.
Yeah, thanks, Melvin, for the comment. There's one question from this session is hybrid, so we also have an online team. So there's a question they're asking, what will be the best strategy for pooling of resources? Well, I have asked the question and I have to answer. So as we say, there's no one size fits all best strategy to pool resources, but the general consensus is we need to establish, large enough pools so that we have what we're calling cross subsidization, both risk and income cross subsidization, so that, you have a mix of the population that is healthy and those who would be sick definitely at some point. But also we have those who are richer and poor, and we have those cross subsidization. So generally, that's my best strategy for pooling of resources and making sure we have good pools for within the schemes. Yeah. Anyone with a better answer? Yeah. Thank you.
I wanted to say it would be interesting to see countries that have a higher UHC index and recognize the strategies that they've used and maybe try to, apply them to our context in our countries.
Yes, thanks. Very practical. Is there anyone, this is the last on my session, anyone who would share, not a question anymore, but just on a lighter note, to just share if you have experience and maybe your country, according to what you said, maybe what coverage have you achieved and what strategies?
No, it's about the complement to previously what you have said. Thank you so much. Mainly if, it was publicly financed rather than, privately financed, it will be a good pool, for example. So if we ensure public financing, there might be outcome in terms of ensuring equity as well as other outcome of the health system, rather than, out of pocket, pulling from out of pocket expenditure and the like. So that's what I'm planning to say. Yeah. Thank you.
Okay, so thank you very much for your attentive and collaboration. I'll welcome my colleague, Dr. Rehab Mbao.
All right, good morning, everyone. My name is Rehab Mbao, as Kazungu has introduced. I think I'll use the mic. Right, yes. So I'll be taking you through the session on Introduction to Health Technology Assessment, and I'll be making this presentation on behalf of my organization, Kemri Wellcome Trust, as well as the partners, and I work in the Health Economics Research Unit. So the outline of this discussion will start by defining what HTA is, why we do HTA, the benefits of HTA, some of the applications of HTA, and then I'll give a conclusion. So what is health technology assessment? I don't know how many of you, by a show of hands, have heard of HTA before. Okay. So maybe I can just pass the mic to just hear some of your opinions, in as much as the answer is there, but yes. What do you think HTA is? Who wants to go? Just from your understanding, it doesn't have to be perfect. There's no one correct answer.
So HTA is anything that we use on patients to prevent, promote. It could be drugs, medicine, buildings, equipment, pharmaceuticals, anything that we use to prevent and promote health among people.
So I'll give a comment on that. So that's health technologies. So any health technologies is anything we can use to prevent, promote, or diagnose with the intention of promoting good health. So that's health technologies. So what is health technology assessment?
I think it's just a multidisciplinary, systematic approach to evaluating health technologies to inform decisions about priority setting and resource allocation.
Thank you very much. Maybe you can tell us your name and which country you're from.
Richmond Osu, Ghana.
Ghana. Okay, thank you. I think my session is over. He summarized everything. So health technology assessment, as he said, it's a multidisciplinary approach that uses explicit methods to determine the value of a health technology. And as our colleague said, examples of health technologies include anything that can prevent, promote, or diagnose health conditions with the intention of promoting good health. So some examples include vaccines, drugs, health services, medical devices, medical procedures, among others. This is just a short list. So the purpose, as our colleague from Ghana has said, it's to inform decision-making and policy-making in order to promote an equitable, efficient, and high-quality health system. So this is what HTA is. So as he said, it's a multidisciplinary process. It uses systematic and explicit methods to determine, our intention is to determine the value of a technology. So the HTA process has several steps. The first one being topic nomination, and here topic we mean health technology. So we nominate a topic, and then it's selected, and then we go through the assessment process, and then it's appraised, then we make decisions, and then finally we implement. If a decision is made to implement it, it's implemented. I'm just going to touch on this because my colleague will talk more on these steps. Here, I'll highlight some of the key principles of the HTA process. So this process needs to be independent. There shouldn't be undue influence from stakeholders. So it shouldn't be that the decision is being imposed, but rather being made jointly. It should be a transparent and a publicly available process. The information about the process should be publicly available. So there should be clear methods and processes, and then the decisions that are made should be well known. So it shouldn't be a black box of decision making. The information should be out there. Then thirdly, a key principle is the timeliness. We understand that the healthcare system is constantly changing. So there's a need to make these decisions in a timely manner to be beneficial, and also to review the decisions every so often as the system decides. Then an important aspect is inclusiveness. So it's important that every stakeholder who will be affected by the decision is involved in the process. And the process should also be scientifically rigorous. So appropriate use of best available evidence should inform this process. And then lastly, a contestability of the decision-making process. And why? We need to know that once a decision is made, we can appeal based on new evidence, or based on whether we question whether the process was actually scientifically rigorous. We can actually appeal and say this decision does not suit, and we see what can be done best. So these are some of the principles that inform the HTA process. So why do we do HTA? Back to the room. Why do we do HTA? Anyone who wants to suggest why we do HTA? Yes. Please tell us your name, where you're from.
My name is Josefa, and I'm from Chile, South America, because we have limited resources.
Yes. Thank you. Another reason? You should have been my co-facilitator.
To ensure safety of health technologies.
Okay.
Okay, my name's Africa Tawetwala. I came this morning, so I just arriving here. So I think it's the principal reason is to enhance health outcomes, which is survivorship probability, because like my country, Liberia, these things are very strange to talk about health technology assessment. But however, there's something which is very unique. You have all the interventions, but if you don't have the proper outcome, I'm sure HTA is one of the strategies that you use to improve outcome. That's to improve health outcome.
Right, thank you. Any other reasons from the room?
Hi, my name is Mariana. I'm from Brazil. In our health system, we use HTA to help the make a decision process.
Okay. Right. So we had a few reasons why we do HTA. And I'm sure some of you have come across such reports. For example, 1 in 10 medical products in developing countries is substandard or falsified. So you can imagine the implications of funding such products. Other ones include less than 1 in 3 hypertensive patients treated in LMICs. So this raises the issues of access to health technologies. Then we have other reports that highlight limited access to antibiotics. So some of these decisions that, you know, the concerns that have been raised in the room, how can we improve health outcomes if people who need health technologies are not receiving them? And how can we make decisions on improving access to health technologies? So why do we do HTA? As one reason has been mentioned in the room, the scarcity of resources. We all know that healthcare resources are limited and they're scarce, right? And a second reason is that there are unlimited needs. So we have aging populations, right? The population is also growing. There's rising burden of non-communicable diseases, and then there's production of new health technologies. You can imagine the demand that all this unlimited needs pose on already scarce resources. So we definitely need a way to allocate the resources. So here, this implies that we need to make a choice, right? So we have limited resources, we have unlimited needs. We need to make a choice. So for example, you have one drug and another drug. Which one will you take over which one, right? So we need to make those choices. So when we were talking about determining the value of a health technology, this is where such choices can be informed by. So the value of drug A over drug B will inform the choice of drug A over drug B, as an example. But how do you determine the value? So there are 3 approaches that you can use when you're using the HTA process. So one of them is cost effectiveness research, where you compare the health benefits and harms of alternative health technologies. So you just look at the effectiveness of one technology over another. The second way is cost effectiveness analysis. So you go beyond the harms and the benefits. So you compare the health benefits of one product over another, but also you look at the cost, and my colleague will talk more about this, so that you just determine the value for money. The third way is the multi-criteria decision analysis, where you compare multiple attributes of different health technologies. So just not one aspect, you look at several aspects of the product that you're aiming to compare. So those are the 3 approaches that you can use while conducting HTA. Right, so for HTA, how do you compile the evidence that you're going to use? Here, I just need you to note that different technologies will require different criteria and evidence to demonstrate their value. So some of the questions that you can begin asking yourself include, for example, clinical efficacy. Does it work, right? Does it work? Then after that is, how much does it cost? So if a drug works, but it costs more, you might want to consider that if you're comparing it to another drug that works and costs less, right? Yeah. So another question again is, who is affected and how? So I've just shown you a report where 1 in 3 people who are hypertensive do not get access to medicine. Is it because we've not considered that it's actually a disease burden? The other one, does it improve the quality of life? We need to invest in something that improves quality of life. Then service use, what is the level of consumption? And then lastly, equity, are particular groups affected, and how do we address this? So these are some of the criteria that you can use or consider when you're thinking of HTA. So why do we do HTA? And some of the benefits have been highlighted here. So it supports the selection of the most effective health technologies, right? The second one is that it promotes efficient use of scarce resources because we invest in things that are either cost effective. So enabling use of scarce resources, efficient use of scarce resources. Thirdly, and this is based on the principle of inclusiveness, it promotes stakeholder participation. So we want everyone who will be affected by the decision to be involved in the decision making. Fourthly, it promotes transparency, accountability, and collective decision making. This again is tied to stakeholder participation, the use of evidence, you know. And then lastly, it supports the process of priority setting. So what are some of the applications? I'll throw the question back to the room. What are some of the decisions in your health systems that have been influenced through HTA processes, through the use of HTA?
Hi, my name is Rekha and I'm from India. So one application can be like to decide vaccination. Say like COVID came and we had to decide if there are like set of vaccination, you have to decide one particular vaccine which can reap maximum benefits with the minimum cost.
Great, thank you. Yes.
My name is Fitsum from Ethiopia, and I would say one of the most important benefits of this approach is to assess or implement benefit specification, because it would allow us to quantify the cost of each treatment cost or each service and be able to make proper prioritization and specification of benefits package.
Benefits package, thank you.
Hi, my name is Saini and I'm from Senegal, and it's more of a question. Yeah, like to clarify my understanding. Let's say we have a scenario, I'm a government and I have $10. And for HTA, and we say, for example, we have the opportunity to invest those $10 into malaria or HIV, or are we only looking at HIV or like malaria and see drug A and drug B, which are we investing? Like, are we looking at specifically in one disease, or also using this methodology to decide what to invest across two options?
That's a fantastic question. Are we using HTA to compare two, let's say, for example, two drugs of the same disease group or two drugs of different disease groups? And again, I can ask experts in the room. Let me ask my co-facilitator.
Very much. So HTA can be used in those two scenarios, either in a disease area, determining which drug is more cost effective or which drug to use, but also between different interventions. So for example, interventions are not comparable in terms of benefits. However, if you need to allocate resources, there is a universal standard. So something like cost utility analysis, where you have a basis for comparing across different interventions or diseases, then still HTA will play a role. Let me give a practical example from Ghana. So in Ghana, childhood cancers were not covered under health insurance. So parents go to the hospital, they pay out of pocket. Then we had to make a decision. The government has to make a decision whether to include it as part of the benefit package or not. And in this case, you realize that then it's going to compete with other resources or other diseases. So the outcome of the HTA indicated that it is cost effective to cover it under the insurance. So the government decided to include it in the benefit package under the health insurance. There is also another HTA that we did, which is about hypertension, disease, medication, I think 2 or 3 of them. And we did HTA to compare which one is more cost effective or gives maximum or optimal value for money. And we were able to decide and prioritize them and all that. So it can be in a disease area or even the general health system. Thank you.
Thank you for that, co-facilitator. Thank you, my co-facilitator. So yes, you can use HTA in one specific disease area or across different disease areas, but you have to have a similar unit for comparison. And some of these things will be highlighted in the discussions which are following my presentation.
Hi, my name is Sophie Shi. I'm from the Kirby Institute at University of New South Wales, Sydney, Australia. I think the missing element here in this conversation is called threshold. So we all talk about HTA. That is a appraisal process to help or inform decision making. But how do you make the decision to buy or not to buy? Then you have to compare one particular product or health technology against a threshold, which is kind of yardstick standard that measure in a common metric measurement. For example, quality, either in quality, incremental cost effectiveness per quality. And this yardstick, this threshold, it's different from country to country, from region to region, and it all depends on your decision making and the healthcare system where you are. So I think that threshold is one element that need to be part of the HTA application here.
Right, thank you. So the HTA process involves several decisions as with evidence, like you have to consider several evidence as we discussed earlier, but what she's raising is the issue of when you're making the decision. So this is the assessment, and then after the assessment, you need to appraise and make a decision. And there are several evidence or criteria that can inform those two processes before you finally make the decision on whether you will adopt or you will make an investment in a particular health technology, or whether you'll disinvest. So HTA can be used to inform decisions on investment and disinvestment. If you feel that once you do the HTA assessment and it shows that it's no longer cost effective among other decisions, among other criteria to invest in a particular technology, then you can choose to remove it from the health benefit package. But the discussion is still ongoing. So in the next sessions, there'll be discussions on the thresholds and decision-making based on the thresholds. And as she said, they vary based on the countries.
Thank you. My name is Dr. Rashid Mahmoud. I'm an academic health economist at the University of Sydney. In terms of this, the HTA application, there's some of the context it don't perfectly fit to assess this couple of precision medicine health technology. Currently, I'm working with this couple of projects with the precision medicine health technology in terms of the artificial intelligence, this 3D imaging. This technology is dynamic. They're also always changing their the different type of algorithm to perform their diagnostic performance in terms of the sensitivity and specificity. How we can incorporate and this type of technology in health technology assessment in the current thing.
So he mentions that health technologies are constantly evolving, and we all agree. For example, if we're to look at in the last 10 years, there are new health technologies that have come up, whether it's drugs, vaccines, or a good example would be the COVID vaccine, which we didn't anticipate, and other things, including X-ray imaging, MRI, things like that. They're constantly evolving. And so you're asking, can we perform HTA on things that have different diagnostic specificity and, such things. And again, as we've said, there's one of the reasons why we do HTA is that there are unlimited needs. And one of them is posed by the constantly new development of health technologies. So any health system, as we've said, has limited resources. So we can't just say we'll adopt each and every new technology that is available. So we'll have to compare the new technology to the existing technology and see whether its costs and its effectiveness actually make sense. And beyond just being cost effective, an important aspect is looking at budget impact. So we can say it's cost effective, but in the long run, what will be the impact of it on the budget? And if it's not affordable, then it's not sustainable. And so a hard decision has to be made. And that's the thing about the scarcity of resources and making choices. Sometimes you're forced to make tough decisions, but explain them based on the evidence that's available. Okay, so some of the applications for HTA, one of them, some have been mentioned here and we'll just touch on them. So there's HTA for development of health benefit packages. And this goes without saying. So yes, you can use HTA to develop health benefit packages, whether it's disease specific or an essential benefit package. So an example is in Thailand, where they use HTA to develop a health screening package under the UHC cover. So some of this you can find the literature and read on it. A second example is HTA for development of essential medicines list. I know Thailand, I don't know whether we have anyone from Thailand here in the room. Do you have anyone? Okay. So Thailand is a country, at least in the Kenyan setting, where we're trying to emulate what they've used HTA for. And one of the things that they've used it for is to develop a benefit package for the Universal Health Coverage Program. And they also use it to develop an essential medicines list. But other countries such as Malaysia have also used HTA to inform their drug policies. A third application is to determine provider payment rates, so provider reimbursements. So you can use HTA to determine what rates will be paid to providers. And this is an aspect of purchasing that my colleague Kazungu talked about in the morning. A fourth application is for pricing and price negotiations. So an example here, we have again from Thailand, a learning experience from price negotiations for vaccines. So Thailand has a very good, they've used the HTA system to inform several decisions, and one of them being price negotiations. So you have manufacturers who submit, let's say, their products, their health technologies, and they give a price. But so what Thailand does is they go through the HTA process. So a topic is nominated and they assess it, and then they look at the price and say, hey, we can offer this at large scale. So can you reduce the price to this much? So they use HTA for that process. Then the fifth application is HTA for development of vaccines lists, which a colleague at the back mentioned. So we can use that. So there's an example here where Italy conducted HTA to determine whether they should adopt the HPV vaccine or the impact of adopting HTA vaccine in their system. Then another application is the list of medical devices. And some of this, for example, include a study that was done in Kazakhstan where they were looking at HTA to influence the use of cochlear implants. So clearly you can see any medical device can be subjected to HTA, and especially if it's a high cost medical device or health technology, because you want to see, does the cost and its effectiveness make sense given the resources available. Then another application is the development of clinical practice guidelines and market authorization. So you can use HTA to advise regulatory agencies whether a health technology should be adopted in a particular system. So this is just a slide to show where it fits, where HTA fits in the bigger picture. So we've talked about universal health coverage, where everyone has access to the healthcare services that they need without financial hardships. And an important aspect of UHC, which Kazungu mentioned, is healthcare financing. So healthcare financing is an important, crucial aspect of attaining UHC. So how the health system is funded. But in addition to that, how are the resources available being used to purchase health services? So how are they being transferred to healthcare providers to provide the services that people need? And what Kazungu mentioned in the morning was that an important decision is, what are you buying? So having the resources that you have, using the resources available, what services are we purchasing? And this brings into focus the importance of priority setting in healthcare. We need to prioritize how we're using the scarce resources that are available. And a good approach to prioritizing healthcare is HTA, because HTA, as we've said, it's a multidisciplinary process that uses explicit methods to determine the value of a health technology. And this HTA process has several steps. So we have topic selection and nomination, and then we have topic assessment. So here you can consider things where you get evidence through evidence synthesis in literature reviews, cost effectiveness analysis, and budget impact. Some of these things will be touched on in the coming section. And then once you assess, now you need to appraise it. And again, here you'll apply a different set of criteria before you finally make the decision. So is the decision, are we adopting the health technology or not adopting the health technology? And then if a decision is made to adopt, we implement it. Right, so in conclusion, HTA is an important approach for explicit priority setting in the health system, given the resource scarcity and the unlimited healthcare needs. I hope that point is clear. The take-home message. Then the HTA process is guided by several principles, which we've highlighted. So it should be an inclusive process. It should be a systematic process. It should be transparent, right? It should be based on scientific evidence, and people should be able to contest the decisions that are made. A third conclusion is that HTA can inform multiple policy decisions, as I've mentioned in the room. So some of them include benefit package development and revisions, price control and reimbursement, clinical practice guidelines, among others. Then lastly, HTA can support the attainment of UHC. And that marks the end of my presentation. Thank you very much. We can take questions. I know there were questions online. Oh, okay. We can take questions in the room.
Yeah, thank you so much. I'm Elias from Africa CDC, Ethiopia. So I think my question is regarding the HTA principle on the timelines to complete one HTA versus the decision making that we are taking, so I mean, like it takes time because we involve a different types of data in the HTA process, but at the same time, the decision makings are very instant. So the same happens in one of our projects at the Africa CDC, especially on the HTA for COVID-19 vaccines. So I think, how do we bring this principles in harmony? That's my first question. And the other one, I mean, I would like to hear from participants regarding their experience. And the other one is like, we make similarity HTA with cost effectiveness analysis, or what makes it very clear difference when we call it, this study is a cost effectiveness analysis vis-a-vis HTA? Thank you.
Right, okay. I can make an attempt to answer the first question. So the first question was on the timeliness, the principle of timeliness. And we understand that decision-making in the health sector, or rather anywhere, basically, the government wants quick decisions made very quickly. And we've seen that HTA processes are long. They can take really long. But there's now recently there's been publication on adaptive HTA, where you can conduct rapid HTA reviews, but it doesn't, the process is not as long, but still can take long. So it can run from a few weeks to months still. And we know that, yeah, policy making needs quick responses. So one solution would be to use an adaptive HTA approach. Unfortunately, we don't have the time to discuss here, but I can share the literature on adaptive HTA. So that's one approach that can be used. The second one, you asked what's the difference between cost effectiveness analysis and the HTA approach. So cost effectiveness analysis is an aspect of the HTA process, and it's one of the criteria that can inform the HTA process. The difference is the inclusivity, like the decision is made with multiple stakeholders on the table, among other things, but I'll allow people on in the room to respond, and then I can add a few more comments.
I just want to say that the HTA is a very good strategy or measures to examine health processes and make decisions. But like country like Liberia, which has not applied this, do you think doing health sector assessment, which also informs the effectiveness of the policies made? For example, last year, we did a evaluation of the investment case by GFF. They made some investment and we did the assessment. And from there, some policies were made, some decisions were made. For example, just a very tiny one. For example, we found out that for family planning, women prefer implant than the others because of the turnaround time. And other decisions, major decisions were made on that. So do you think if you don't have the SDA and you do health sector assessment, will you miss out everything? Or you think it's almost the same in terms of providing policy decision for government? I just wanted to know the difference.
Right, okay. Thank you for the question. Maybe I can just put the question back to you. What are some of the things that were considered in the health sector assessment? That's what you called it? What was the process like?
It was mainly about RAMCA, reproductive health, adolescent, maternal health assessment, RMCH in short. So we were looking at emergency obstetric care. What were the issues affecting emergency obstetric care, prenatal care, postnatal care, and neonatal care? So we were looking at all of these, and the outcomes were the mortality level, and also the readiness of the facilities. So from there, a lot of decisions were made. For example, readiness was affected by electricity, was affected by road network, was affected by absence of ambulances. And also the mortality level was affected by neonatal mortality, particularly less than 11 months old, that inflated infant mortality. So we look at that and say, well, in all, although you had high increase in prenatal care, high increase in delivery in hospitals and by trained persons, but the major outcome of death was still high because of the quality of delivery. So, I mean, I'm just to give you a gist of what was done, but because the HTA is almost like maybe on the other side, looking at how well can you do the investment so that when you priority, so as you do priority in terms of what is the best, and it also informs you on a lot of issues that you could get from say impact assessment or evaluation. That's why I say let's see how those are all that have not used the SDA, whether we have lost out a lot. That's what I wanted to know.
Okay, thank you for the question and the comment. So I have to say that obviously the adoption of HTA is still lagging behind in low and lower middle income countries. So HTA has been institutionalized in high and upper middle income countries mainly, but there's interest in low and lower middle income countries to institutionalize this. And we'll talk more about that in the afternoon. But to answer your question, assessments always happen in the health system. So for example, that health sector assessment was a process to just gauge the performance of the health system, basically, because you're talking about reproductive, maternal and newborn child health. So what I would say is HTA is, for example, if someone had come up with a new mode of family planning and you wanted to compare it with what was existing to see if we should adopt the one that is being proposed, that would be an example of a HTA process. So what, of course, assessments will also always happen to determine the quality of care and to see areas of improvement. And that evidence may inform decision-making, but it's not necessarily a HTA process where you're comparing alternatives, towards service delivery. Another question?
Yeah, I have a comment and a question. The first comment is from for the question we asked the good sir from Africa CDC regarding equating HTA and cost effectiveness. As someone who's only hearing about HTA today, the way I'm understanding it is like it goes beyond that, and that's the aspect of multidisciplinary that he's talking about. I think, for example, if I think I would better explain it using an example. Let's say we can have two drugs, drug A and drug B, and drug A being less expensive than drug B, but it can be in a context where drug B will be more suitable. Let's say a country like Senegal, which is 97% Muslim, if we had a vaccine that had pork in it, like regardless of how cheap the other alternative is, we are going to go with the more expensive option. So then like we are making an analysis that goes beyond the financial aspect of it.
Yes.
Yeah.
Yes. So you raise a very good point. Let me just go back to this slide. Yeah. So we talked about nominating a topic. So what he's saying is that, so someone says we have two drugs for particular disease, but we want to see which one will adopt. Then you analyze it. This is the assessment phase. So you look at things like if costs, effectiveness, and whatnot. Then you come to the appraisal phase. And this is where a lot of this, and other aspects of criteria are considered. And in here, some of the criteria that are considered are social values. So if, as in his case where he said, majority of the population is Muslim, if a content of the vaccine is not considered acceptable in the local community, it will not be absorbed. So there would be no need to invest in that particular drug because there will be low uptake, which will lead to inefficient use of the resources. And so based on that social value, then a decision can be made to adopt or not to adopt that drug or technology, then that will affect its implementation. So that's a very good point. I hope that example has come across. Yeah.
And the question that I had was regarding the principles. The first one was independence, I think. Usually, the question is related to the politics of HTA, who funds them, and also like the power dynamics between the stakeholders that are involved into the decisions to be made. For example, if the government says this is what we want to invest, like what weight does the other involved stakeholders have in the decision making process, like based on experiences of the those 6 or 7 examples that you have shown?
Right. Thank you. That's a very good question. Let me just start by saying priority setting, where health technology is also an aspect of priority setting, is both a technical and a political process. You can't avoid the politics. The politics has to be acknowledged in the process, and that can influence, the decisions that are made inevitably. So when I talked about independence, ideally, this would be in an ideal situation. So you'll have the organization or the unit responsible for the focal point for HTA. Some are funded by government resources, some are funded by donors, some are funded by those manufacturers who are submitting dossiers for the products to be assessed. But it has to be clear that the decision was based on a transparent and a publicly available process. In as much as they're submitting, they're funding the process, it doesn't mean they have a big take on what the decision will be to include or not to include the drug. So I'll use the case of HTA, which receives funding. HTA is the health intervention technology assessment program in Thailand. And I really wish there was someone in the team here. So they receive funding from government, but also manufacturers who submit dossiers are required to pay for that. But it doesn't mean that they will influence the decision at the end of the day, right? So these are ideal. We understand that the politics may take over and compromise the process. It's not perfect, but we make an attempt. Yeah. Right. Oh, okay. Okay, just to highlight, we have just 5 more minutes. I'm happy to take questions during tea break. Yeah. Oh, from HTA?
Okay. Okay. So thank you very much for your presentation. I have one question. Can you please go back to your previous slide where you talked about the, yes. So here I have a question that in developed countries, we understood that people or you can say patients are aware about the choice, and HTA talks about the informed decision that we need to take because of this help. But what about low and middle income countries where people are not very much aware about the different packages which are there, and we are comparing that which package or which drug A or B is better for the treatment. So when we have one, you can say information point, that is service provider, how this HTA will be effective in that particular scenario where people are not very much aware. They can't do, they are just, they are dependent on service provider. Which one the service provider is suggesting them to take could be like package 1 or package B, the package 2 in that particular sense. So how, I mean, is there any provision of making people aware about the choice, that how they can make informed decision or a cost-effective decision in HTA, or it is still like we need to work on that? Thank you.
Okay. Thank you. So what I have to say is, let me just clarify, the HTA process can be done at the national level, at the sub-national level, and this will inform decisions that are made by the provider at the provider level, right? And at the national level or sub-national level, you'll have the government as one of the decision makers. You'll have, at the sub-national level, you'll have the sub-national units as decision makers. But an important aspect of this process is making sure that it's inclusive. So you have all the stakeholders will be affected by the decision, or representatives, let me say that, because you can't have everyone in the room present during this process. So again, let me use an example of NICE. They have a citizens jury. So members of the public, but this, anyway, it's a citizens jury that has members of the public, and they can participate in this process of the HTA process, with the intention that once the decision is made, then it will be passed down to the healthcare facilities so that they know that there's, let's say, HPV vaccine is available to be given to patients. But I understand where your concern is. You have a patient who's coming to a health facility. How do they know? And this is where purchasers, which will include the government, social health insurance, or the national health insurance, they have to do a lot of work in communicating the health benefit package and stating exactly what is in it so that its beneficiaries know. So that will be, you know, beyond the process, but having a citizens jury or lay people represented in the process is important. And just to clarify as well. So like in Thailand, they have this process for vaccines, and they have this process for, for drugs, and have this process for services. And drugs might be too technical for the lay people to, to be aware what drugs are there. So they might not necessarily be involved in the process, but they'll be informed of the outcome of the decision, right? Yeah.
Hi. I am just wondering about your opinions on the HTA process. We know HTA process, they require a lot of evidence, data, and manpower to go through the process properly. That costs money. So in the context of the middle and the developing country, I think the problem is more, severe, right? They are lacking their resources. So when you spend money to do the HTA, what's the opportunity cost for that? If you got money, to probably to fund treatment, and instead you're going to use the money to do a HTA process. What's the opportunity cost for that HTA? That's one question. Another one, oh, I can't remember now. Okay.
Sorry about that. Yes, you do raise a good point that a HTA process is resource intensive, and this will come across in the afternoon when we're talking about factors that influence institutionalization of HTA. And so in lower middle income countries, which, as you correctly stated, have a severe shortage of resources, especially financial resources, it begs the question, do we fund the process or use the money to fund, the drugs? Again, I mean, it's a complex situation, but at the end of the day, maybe you can ask yourself, what's the impact in the long run? And so some of these decisions will be, okay, so the HTA process is resource intensive, but to what extent will not doing a HTA process actually impact the health system in the large, at the end of the day? So already we know, and just a comment, the WHO report said that 20 to 40% of the health system resources are wasted. So do we want to continue wasting, or do we want to invest in a process that can help us reduce the wasting? Maybe that's what we should be asking our governments and the purchasers, right? Yes, it's an expensive process, but do we continue wasting the money or invest in a process that can help reduce the wastage? Yeah.
Just to add on that. So she gave also an example from HTA, where they use the process to do price negotiation. Okay, so in as much as it's cost intensive, it can be cost saving if you're using it to, for example, regulate or negotiate for the prices that you buy for the commodities you're looking for. So as said,
So, so you have just mentioned about the threshold setting. So I'd like to know how this threshold is being set, and is it a universal one, or does it like vary depending on programmable interventions?
That will be answered in the next session, so that we save time. But yes, the discussion will happen.
Yeah, I was going to comment on the value of doing HTA versus investing, using that money to invest or to buy services. I think one of the things, it's a valid question, but one of the things we often underestimate is the opportunity cost of wasting the little resources we have in low-income settings by not using them in a wise manner. So, I think there's still rationally for strengthening our system. It doesn't have to be full blown, all the fancy stuff, but the thinking helps a lot in using the limited resource. And in the long term, there has been evaluations done in Thailand and in some of the countries which have institutionalized these processes, and the return on investment by doing that kind of approach is in 100 times more valuable if we were to do the decisions on ad hoc basis or otherwise. So yeah, and it takes only a small portion of whatever that is a bigger exact.
Thank you for those comments, and I want to thank you all for a wonderful and enriching discussion. Oh, sorry, one last one.
Because I remember my question now. Yes, another question will be that from the perspective of industry, they try to invest a lot of money in the new innovation, new technologies. And they may see the process of HTA as a barrier, stop them from, taking the technology from the lab to the healthcare system, to the patient's bedside. So I just want to have your opinion on that. What's the HTA's role to help the industry to, to promote the innovation, to improve the population health in the long term? Thank you.
Right. So that's, again, a good question in terms of And what I hear underlying the question is the interests of the industries. They're interested in innovation. They're interested in ensuring that, they produce things that can promote good health. So a HTA process can be viewed multiple ways by industries. And if you join us in the afternoon discussion, you'll see it can actually influence how the HTA process is conducted and institutionalized. And it's because they might perceive HTA as a barrier to those innovations, because now they know that we produce this technology, but it has to go through an assessment process, and they might perceive that as a barrier. So I think the important thing here would be to create awareness and communicate with the industries that this is why the HTA process is being done, and this might be the influence. And it's true, as I said, HTA can lead to hard decisions. There'll be winners, there'll be losers, the people who will not be happy, but it needs to be clear why the decision was made. So industries will be affected, and also patients, providers, some of us as stakeholders will be affected by the decisions that are made. All right, in the interest of time, we are supposed to be back here by 11. So there's an empty space. So we'll move into the next session. I hope you enjoyed your tea break. And you have enough energy to participate in the next session. So I'll invite the next presenter. Yes. Welcome, everyone.
So thank you for being part of the training workshop. My name is Angela Cairo, and I'm with Camry Wellcome Trust in Nairobi, Kenya. I'll be presenting on the components of the HTA process and its institutionalization as well. So a lot of what I'll present has already been preempted in the previous morning sessions. So for those slides, I'll just quickly go through those slides and then now get to what we need to talk about. So the outline of my presentation will be mainly on the steps to conduct a HTA, so the process itself. And I'll do this in reference to a case study, so specifically for Thailand, because as my colleague has mentioned, we have been working closely with them as we develop our own process in Kenya. So just to give you an example of that, in the afternoon, we'll have a different case study as well. So at least you'll be able to have different scenarios and see how the different countries have taken up the HTA process. And lastly, an example based on the different processes that HTA speak to within Thailand. So I think we in Rehab did a good job in defining what HTA is, and we were able to understand that it's more of a multidisciplinary process that gives us explicit methods in decision-making across different health technologies. And this is to ensure that these decisions speak to equity, efficiency, and high quality within the health system. Again, the different applications of HTA, I think those were mentioned quite widely. So benefit packages, they inform benefit packages, essential medicine lists, lists of vaccines and other medical products, informing pricing as well as price negotiations for different health technologies, can be used to advise regulatory agencies when it comes to the use of technologies, whether those that are existing or are new, and also advise purchasers for healthcare. So whether it's the National Health Insurance Organization in a country, the Ministry of Health, regional or national governments, on reimbursement amounts of different health services, and also advice on development of various clinical guidelines. So I think this we had mentioned in the previous presentation. That's just a recap of that. So we'll go straight into the functional components or the steps taken in a HTA process. So the first step is topic nomination. So what does this step involve? It's basically a proposal of items or health interventions that are to either be included in the various applications for HTA. So it could be a health benefit package, it could be an essential medicines list, vaccinations, or any other new technology that's being introduced into the health system. So you have a wide range of health interventions that are proposed. So from this wide range of health interventions, you then need to narrow down that list, and that involves the second step, which is a topic selection. So you need to decide from the 100 interventions that have been proposed, which 2 or 3 you will then go ahead and conduct the HTA process on. And this step we call topic selection. So here we employ priority setting processes to identify the healthcare interventions for further consideration. The third step is the assessments, which again had been lightly spoken about. And in this step, you then take the health interventions that were selected through an assessment process so that you're able to analyze the information about the interventions against priority setting criteria. So here is where you get to do your cost effectiveness study, cost utility study, and your budget impact analysis. So you've done your assessments, you've done your analysis, you have a set of results with interpretations of what those results mean. So you have evidence that now can inform a decision that can be made about a health intervention. So the next step is now the appraisal step. I'll speak in detail to this throughout the presentation. This is just an overview. So the next step is the appraisal step, which is basically making a decision about the health intervention. And this is based from the evidence that you collected or you were able to analyze during the assessment process. Okay. So in the appraisal decision, the assessment team, based on the results that they've generated, are able to give recommendations on what they think should be done at that point to the decision-making bodies. And the decision-making bodies are the ones that then now decide whether they will implement or not an intervention that has been proposed. And this now speaks to the fifth step, which is executing the mandate. So this decision or the entire process can either be considered to be an advisory process, okay? So here you provide the evidence, you provide a recommendation, and you let the decision-making bodies decide what they're going to do with that information. Or it could also be a regulatory process whereby it's enshrined within law. So that will require more legislative frameworks that will need to be established. And again, as we speak through the presentation, this might, I think, add more comments to the impact that HTA has, especially in the industry sector or in the private sector. So it just depends on what a country or what a country is able to do based on advisory or regulatory functions. Once you go through these 5 steps, you're then able to decide whether the intervention will be included in the benefit package, the essential medicines list, the vaccination list, vaccines list, or any other use that the country is using the process for. So we'll start with the first step, which is the topic nomination. And as I go through these steps, with every step, as I'd mentioned, we'll use Thailand. So if there's anyone from Thailand to add context to what we present, that would be lovely. But we'll use their case to see how they go through the HTA process. And we can also get more insight on countries here that have an established HTA process and how they do it after the presentation. So as I'd mentioned, the first step is topic nomination. So you get proposals from different either stakeholders or institutions with the different interventions that they require the HTA to assess. Yeah, the HTA process to be conducted. And this could be done by a number of, in different ways rather. So if we look at how Thailand has done it, because, and they, as I mentioned, they use the HTA process for 3 functions. So one of them is to develop their, or they use this rather to develop their UHC benefit package. So if we look at this process, the first step that they undertook was nomination of different interventions. So you have a wide range of health interventions from different industries, whether it's a public sector, the private pharmaceutical industries based on their different interests. So they hand this in. And once these are handed in, they have different working groups that go through these different proposals, or rather, they're the ones that hand in the different nominations for the different health interventions that they wish to be assessed within this process. So looking at how they do it, they have a wide range of stakeholders that are involved in this step. So the first step. So you have policy makers. So this could be the Ministry of Health or governmental organizations. You have the health professional bodies, academics as well, or research institutes. They also involve the patient groups in providing nominations for interventions of their interests. In addition to that, we have the civic society as well. So the patient groups, civic society, and the lay people has the component of public participation within their process. And lastly, we have the industry as well. So this could be either the pharmaceutical industry or private health sector, either in terms of a health facility or other institutions. So these groups of organizations submit their nominated health interventions that they wish to be assessed. So the different groups have probably submitted 1 or 2 or 3 health interventions, right? So from what has been proposed, we then need to select what will be assessed, because we can't, based on the capacity that's there, more than not, you're not able to do assessments on very many topics, right? So you probably select 1 or 2 or 3 based on the country's capacity to do the assessments. So we need to then select which interventions will be assessed. So this is usually done based on priority setting criteria. In most cases are not, it's context specific. So different countries have different criteria that they're looking at that will assist them in selecting what intervention needs to be assessed first and what you can put off until later on. And I think most of us are researchers here, and we all know whenever we are starting a project, the most important thing is, first of all, getting the question right. So even in this context, the most important step is getting the question right, because then this makes the work easier in terms of how the results will be received and how they'll be interpreted. So for the HTA process, this should be justified and it should be useful enough to inform policy. So again, if you end up targeting an intervention that's not of interest within the country's context at a particular time, that information may not be used by the ministry, or it may not be useful. So it's important to ensure that this is a consideration that's put into place during this process. So how then do we make sure that the interventions or the topics that are selected are relevant to policy? Because remember, again, as researchers, we always want to marry the work that we do and the findings that we establish to the policies that are being made to our country. So one of the considerations is the inclusion or the inclusivity of the process. So who you include in the process of the topic selection. So remember, in the topic nomination, we had a wide range of the working groups that nominate the topics that need to be assessed. And in the topic selection as well, we need to consider these groups. So you need to consider the professionals, you need to consider the institutions, whether it's the government or the private sector. You need to consider the lay people or the civic groups or the patient groups as well. And in including these groups, you then ensure that whatever you're assessing is based on the needs of the population in terms of their health. So the inclusivity of a wide range of stakeholders. So if we think through the Thailand process and the step for prioritization, so those are the working groups that are involved in the topic nomination. And then you have the prioritization step. So the groups involved in this step are a much smaller group of people, not as wide as those in the topic nomination, because as we had mentioned, this can be a very resource intensive process and time consuming process. So as you go along the different steps of HTA, you need to consider who to include in order to make it as practical as possible or as efficient as possible. So for the Thailand team, they usually have a stakeholders working group. So it's basically a smaller number of people from these 4 groups. So you have the health professionals, the academics, the patient groups, and the civic society. So representatives from those groups form the stakeholder working groups, and they're able to sit down and go through the nominated interventions. And based on a particular criteria, they're able to select what can be assessed at that point in time and what can be put off for later. So this is an example of the criteria they use. So once they get the different interventions from the different disease groups, they look at the magnitude or the severity of the problem within the country, the effectiveness of the intervention, the variation in practice, the financial impact on households, and the equity and ethical dimension of the intervention. So this is what they look at. So for Kenya as well, as we were developing our UHC benefit package, we had a 10-point criteria that spoke mostly to some of these areas. So where we looked at the effectiveness of the intervention, the disease profile of the population, amongst other things. I think we'll be able to touch on that during the discussion. And that is basically what informed the interventions that were considered for the universal health coverage package. So this criteria is important for every country to establish in order to help with the prioritization process. Okay. So you've narrowed down the topics that you've selected, and at this point, maybe you have 2 or 3 that have been considered for assessment. So this leads now to the next step, which is the assessments. And this is the process where you analyze the information about the interventions against the priority setting criteria. So the assessment process, I think Rehab touched on it, but the first thing to do is that you need to gather evidence on the intervention and maybe the population as well. And that could be done through system reviews. So that could either be a rapid review based on the time that's available for that information to be produced. So it could be a rapid review, it could be a scoping review, and if you have enough time, it could be a systematic review. So basically, this is where you have the evidence synthesis to start with. Once you've collected this information and you know what's required, you can then go ahead and do the cost effectiveness analysis, where you're able to look at the costs of implementing this intervention in addition to the effectiveness of the intervention. And because that's only one aspect of the assessment, if we know how cost effective an intervention is, we also need to know how sustainable it is. So you would then do a budget impact analysis and be able to extrapolate this either over a number of years, which will then inform the government on how much it will cost over whatever number of years that intervention is required. So we go back to the Thailand case. So once they have selected their topics, they then conduct cost effectiveness analysis or cost utility analysis, depending on the outcomes that are being assessed. And in addition to that, a budget impact analysis. Yeah, so as I mentioned, you look at the effectiveness and the costs as well. And for the costs and the effectiveness, you could either do a primary analysis of data. If this is not possible, there's secondary data or secondary analysis that could be conducted. And this is usually backed up by evidence synthesis or reviews based on these 2 components. And from that, you are able to conduct a cost effectiveness or cost utility analysis in addition to a budget impact analysis. So looking at both affordability and affordability and sustainability of this intervention. So I'll just briefly define the cost effectiveness concepts, but the next presentation will give more detail on this. And for a cost effectiveness analysis, we need to conduct cost analysis. So you measure the costs of the interventions in monetary terms and look at the effectiveness as well, which is a measure of the health benefits. So this could either be done through unidimensional outcomes. So here you look at life years saved when you implement a project, or the deaths avoided for, let's say, vaccination programs or community health programs. You could also use multidimensional outcomes, which look at both the quality of life and the quantity of life, such as the DALIs averted or the QALYs gained, okay? So you have your costs, you have your health benefits. The next thing you need to decide with these two results is whether the intervention is cost effective, right? So you have your costs, you have your benefits. You then need what we call a decision rule in a cost effectiveness analysis, which is basically a threshold that will tell you whether an intervention is cost effective or not. And if the intervention is below the threshold, then it means that the intervention is cost effective. So we'll speak more to this. So when you have your costs and your outcomes, you're able to calculate what is called an ISA, so an incremental cost effectiveness ratio, which is basically a ratio of the costs, the difference in costs, and the difference in benefits. So you have two options that you're looking at. You calculate the difference in that, divided by the two options of the effectiveness or the benefits of the health intervention. When you do this calculation, you generate a ratio, which we call the incremental cost effectiveness ratio. Okay, so I have a very brief exercise, very simple maths here. I think we can engage in this. So we have two options, just a hypothetical example. We have two options of drugs. So drug A and drug B. The costs for drug A is 3.9 USD, and it's required to take 2 doses of that, and it's required for the entire year, so for 365 years. And the DALIs averted, or the health benefits, is that it averts. So DALIs is disability adjusted life years. It's basically a measure of morbidity or mortality, or the disease burden within a population. So the DALIs averted are 1.5. Then you have drug B, which costs around $7. It needs to be taken twice a day and for the entire year. So that's 365 days. And the DALIs averted are 2.9. So I think with this information, you can't make a decision on what to pick and which one would be more cost effective, right? So you need to do some calculations. So I think the first thing maybe we can do quickly, even on our phone calculators, is what is the annual cost of drug A and drug B? So just quickly, maybe someone can give us an answer on that. Let's look for the other microphone.
Yeah, I just say $2,847.
That's for which
Drug A.
So 2,000? Okay. And then for drug B, what's the annual cost?
$5,110.
Okay. So correct. So the first one is just a round off. So you have the first drug costing around $2,000 and the second drug costing around $5,000. If you look at the health benefits of the effectiveness, we see that the DALIs averted is 1.5 for drug A, and the DALIs averted is 2.9 for drug B. So the more DALIs that are averted, the better the intervention is, because you want to avoid them, right? But you can see that it might be more effective, but it's also more costly because it's around $5,000. So then you need to make a decision based with this information on which one is more cost effective. So at this point, we then calculate the cost effectiveness ratio, right? So remember the formula where you have the difference in costs divided by the difference in the effectiveness, okay? So that formula. So that's how you generate the cost effectiveness ratio for two interventions. So I'll just quickly give you the answer to that. So there's a difference in the cost and the effectiveness, and you get an ISA of around $1,615, right? Now we have the ISA, but this doesn't tell us much about what decision to make. So we then need the decision though, okay? Which is basically the threshold below which an intervention is effective. So the threshold is an arbitrary concept. I think different countries use different thresholds. The one that has been used mostly in the past was the WHO recommendations where use the 3 GDP, 2 GDP, and the 1 GDP to determine the cost effectiveness. But after a few studies have been done, I think it was found to overestimate these thresholds, especially for LMICs. So based on some work that had been done, one of the proposals was to do half the GDP for LMICs. So in this case, we assume this is an LMIC and we use half the GDP, right? And it comes to around 908. So this is a threshold. So if we look at the ISA that has been generated and the threshold for this country, what would be the conclusion? I think this is very straightforward. Someone can just lift their hand. So what do you think that drug B, because that's the one that preceded in the calculation, do you think that drug B is cost effective or not based on this threshold? Yes or no? Okay. So yes, so I agree. So if for drug B, it indicates that with a threshold of $908, it may not be cost effective to implement it, okay? And therefore, if this is a drug that needed to be included in the medicines list, you would not consider it based on the information that's provided here. Okay. Now, maybe I can just go back to this, but the next session will speak to this. Again, the decision on whether to include an intervention based on the ISA or based on the threshold, the ISA that has been generated, again, is done against a background of other criteria. So I think we had mentioned that you have the social criteria of the country, any ethics, legal. So this might not be the only piece of information that's used to make that decision, but it adds on to the evidence that the decision-making body might require. So as I've been speaking through, we've been looking at the Thailand case, and they usually use their HTA process for 3 functions. So the first one is the UHC benefit package. So they use that. And here specifically, they look at non-pharmaceutical benefit package. The second thing they use it for is their essentials medicines lists. And for this, again, they look at the pharmaceutical benefit package and more specifically, the high cost technologies or drugs or interventions in this case. And thirdly, they use it as well for public policy evaluations. So these 3 functions or these 3 objectives are what are used for HTA in Thailand. So we've talked about topic nomination, topic selection, and assessments, right? So we'll go to the next steps. And here we need to look at the appraisal step, right? So you've generated your ISAs, you've interpreted it, you've presented the information, it's cost effective, it's not cost effective, based on these costs and benefits. So then you need to make a recommendation to an institution or an organizational structure, right? So if we look at the UHC process or benefit package in Thailand, they have a governance structure that is able to make the decisions on whether it's included into the benefit package or not. So to begin with, at the very bottom, we have the several groups of stakeholders. So these are the ones that are involved in the topic nomination and selection process. You also have the HTA agencies as well. So in most cases, these are the ones or organizations that conduct the assessments. So HITAP is the one that's well known in Thailand that does the assessments. And from the information that's generated, this is then presented to what they call a health economic working group. So it's basically a secretariat composed of their national health insurance organization in the country, the staff from that institution. They form the health economic working group. And once they present the evidence that they've generated to this economic working group, they have a subcommittee that's specific to health benefit package, because remember, it serves three functions: the health benefits, the essential medicines list, and the public policy. So they have a subcommittee for health benefit package, who they present their evidence and recommendations to. And these are then forwarded to the NHSO board, which is the National Health Insurance Institute in the country, and it's chaired by the health minister to make the decisions, okay? So that's the governance structure that they have for the HTA process specific to the UHC benefit package. Now, different countries may have different governance structures again, because this is usually largely informed sometimes by the capacity within the country to form some of these subcommittees and groups, and just basically how the governance structure in the health system looks like. So it could be context specific. It doesn't have to adopt this same structure. Okay, so yeah, so that was it. So for these 2 steps, the one thing that we learn from Thailand is that it's a participatory, transparent, evidence-based, and contestable because of the public participation concept or inclusion that they have. So based on the stakeholders that are involved and the structure as it is, this process is quite transparent, it uses evidence, and it can be contested, okay? So it's not implicit or opaque in terms of how these decisions are made. If you look at the essentials medicines list, the governance structure is more or less similar. The only difference is that we have now a subcommittee for the essentials medicines lists, because it looks at this intervention specific to this. And the decision-making body is basically the National Drug Committee chaired by the Prime Minister, okay? So the topic selection, nomination, selection, assessment, more or less the same groups, but then as we head towards the decision-making process, that changes a bit, okay? Now, if we go into more details in terms of who's involved in this, we find that at the very top, you have an expert panel. This is specific to the essentials medicines list. We have an expert panel of 22 individuals, and this is actually in the nomination process, and this mainly includes academics. So you could have, either research institutions or universities that are involved in this type of research. You have the industry as well, the pharmaceutical industry or the private industry, and you have public hearing where you involve the public or the lay people in the process of nominating the process of the interventions. So once the stakeholders are able to nominate, there's a screening group that works to narrow down the list that has been nominated or provided. And this is usually from 24 working groups. And once they select the topics to be assessed, they then conduct a cost effectiveness. They include the aspect of equity as well, and national affordability. So like budget impact analysis. And these results or recommendations are forwarded to the subcommittee. And finally, the committee that is headed by the Prime Minister to make the final decision. So as we speak through the essentials medicines list and the UHC benefit package, We can see in Thailand, this process is mainly advisory more than regulatory, right? So they give the advice, the decision-making bodies on what needs to be done. But these are the guys who ultimately decide whether they'll include it or not. Okay. And some of the criteria they look at specific to essentials medicines list is the safety of the drug or the technology, the administration restriction, the frequency of the drug administration, and the efficacy and effectiveness. So remember, for the UHC benefit package, they had their own criteria. Then for the essentials medicines list, they also have a criteria for this. And when we think about essentials medicines list, it can be a very extensive list to look at. But for them, they chose to focus on high cost drugs specifically for this assessment, and not the ones that are low cost. And we'll just look at the different class of drugs and which ones speak to the high cost drugs. In addition to this process and getting the cost effectiveness and equity and affordability, the other thing that the HTA process does is that they use this for price negotiations for new interventions or existing interventions as well. So we'll see some examples whereby they've been able to negotiate for lower prices for drugs, and this has been effected. So based on their essential medicines list, mainly it's done for the class E2, which are the high cost drugs, for particular groups of patients. So it could be either for cancer patients or other NCDs or communicable diseases, but not for the entire list of the essential medicines. So again, based on the context of the country, you could target these to what is really needed by the country. So for them, they thought this would be the most contentious or the most appropriate to conduct HTA on. So a few examples on how this has been effected into policy in Thailand is that they've managed to include a couple of drugs into the essential medicines list based on the assessments that were done. And between the development of the guidelines for the essential medicines between 2007 and 2010, they included 2 drugs. So yeah, one is for HIV, if I'm not wrong, tenofovir, into the list. And the other one is this one, starting with a P. My pronunciation is a bit difficult, but that one, that one was also included into the list. So again, you're able to see how this can be used for policy, or the information can be used for policy, right? Another, yeah, so back to our example. So we had calculated an ISA of around 1,600. And we concluded that based on this ISA and the threshold for this country, that the drug should not be included in the medicines list, right? But remember, I'd say that the other thing that Thailand uses the HTA process for is price negotiation, right? So if we reduce the price of this, would we then be able to include it into the medicines list? Yeah. So if you reduce the price, it will most likely reduce the ISA, okay? So for instance, if we were able to use these results and approach the industry and negotiate for a lower price of a new intervention, that would definitely reduce the ISA, and it would then make drug B cost effective, right? Or considered to be included into the essential medicines list. So an example of a drug that was negotiated and the price went down and it was included in Thailand is this one, oxaliplatin. So the initial price of this drug before the assessment was done was around 8,000 baht. But after the results were generated and there's a negotiation with between the ministry and the industries, they're able to get down the price to around 2,000 baht. So again, I think even as a basic concept in life, by the time you negotiate for something, you need to have information so that you know what you're negotiating for, right? So this is another way that these results or evidence can be used within the health system. So you have the information and you have a basis as to why you're saying, instead of selling for us this drug at 8,000, why don't we get it at 2,000? Okay. So just the importance of that. Here we have various drugs that were also negotiated down, again, in the Thailand context. And as you can see, it's quite significant reductions. Okay, so like for tenofovir, from an original price of 43 baht to 12, that's more than half the reduction of that cost, right? Another example is this last one for hepatitis C, so for sofosbuvir, so from 1,500 to 130. So you can see what evidence or the impact that evidence can have when you're making policies. Okay, so I think it's important to consider the HTA process in this context as well. Okay, so as I'd mentioned, we have 5 main steps in the HTA process. So you have the topic nomination, interventions are proposed. You have the topic selection. The proposed interventions are narrowed down based on a criteria. You have the assessment. You analyze the information for the selected interventions, okay, and generate evidence and recommendations. You have the appraisals. So here it's decision-making about the health interventions based on evidence. So this body recommends whether or not to implement an intervention. And lastly, you have execution of the mandate. So the decision body decides if the process is advisory, the recommendation is just provided and the decision body makes the decision. If the process is regulatory, then, that's implemented based on the law, right? So those are the 5 main steps of a HTA system. That I'll end my presentation. Thank you for your attention, and I'm open to any questions. So we can have any questions or comments or even experiences from countries that have established HTA systems or processes.
Thank you for your presentation. So in the case that you presented of high cost drugs, the price negotiation can basically produce savings, but also having, a threshold might mean that some low cost drugs get kind of pushed up in price, given that threshold. So I don't know if you have any comments on kind of the reverse of the savings in the context of HTA.
Okay, please let us know your name and where you're from.
My name is Josefa and I'm from Chile.
Okay. So I think it all boils down to the purpose of the HTA process in a country. So, if your target is just the high cost drugs, then that means you won't assess the other class of drugs, so the ones above, to include into this. So it just depends. If that's a purpose or the objective of the HTA, then that can be done as well. So it depends on what the purpose of the HTA process is or the assessment is. And then again, remember, you have to consider the criteria as well, because they're not just looking at the numbers that are produced. So even if you have a low cost drug, what's the effectiveness of the drug? What's the population coverage that the impact, the intervention will have the impact on, and the different assessments? What's the financial protection as well, if you decide as a government to cover this? So you have the criteria that you look at as well against that information. Yeah.
Thank you so much for the presentation. I think a lot of the pieces are coming together now from the last 2 presentations and this presentation. And I think my question will be that I wanted to ask after the last presentation is even more present now. So in the last presentation, we did have quite a number of data points that were mentioned we need to focus on and to make the HTA work. And the cost benefit analysis and cost utility are just one part of it. And so the question I wanted to ask earlier is, of course, it's not the cost effectiveness and this cost utility or ISA alone, but are there metrics also that you can put in all these different data points so that it can help to give you a holistic view of whether this is worth doing or not? I think if there is such platform or tool, I think that would be quite helpful to see how the different bits of evidences that we're generating can be put to use beyond the effectiveness analysis and what have you. And just to say that for Chai, the organization I work with, I know we've done quite a lot of market shaping in the past as an organization, lowering cost of HIV drugs and what have you. And maybe what I didn't know, because maybe I didn't join then, was whether it's the same process of HTA that they used to negotiate this price reduction with the companies to enable countries scale up the treatment also. But it's quite helpful to see this coming all together. Thank you.
Your name and where you're from, please.
I'm Ashur Abubakar from Nigeria.
Okay, thank you. So I can maybe take one more question, then answer that. I'll take questions in pairs. Yeah.
Thank you so much. I am Mulukan from Ethiopia. It was a nice presentation. Just, I have two questions. I think that's okay. My first question is like, so whenever the ISR of the drug is below the threshold, then they will keep on including it, yeah? So what is the limit for including the drugs? Because at some point, I mean, it depends on the resort, yeah? So one thing I want a clarification on that one. So they go for another analysis to define, or I mean, like they will take out other drug from the already existing list and the like. So, so what I need explanation on that one. The second thing regarding the threshold. So this is recommendation, like again from a study, like the 50% of the GDP and the like. So should a country do its own analysis or threshold defining exercise and the like? So that's my other question. Probably, if I'm allowed, I'm a bit confused about the way the Thailands are doing this, because once you include an intervention, that means you include the drug that is used for that intervention. So how are they doing to separate? So there is one prioritization for interventions and they are doing another prioritization for essential drug use. So I can't bring this to, because I mean, like if you cover the intervention, that means you put on the drug in the area. So a bit of clarification on that one. Thank you.
Okay, so maybe I can just start with those questions. With the last question. So an intervention does not specifically mean a drug. So with the UHC, you could find that it's a health service. It could be a diagnostic tool. It could be a vaccine. It could be a drug. So even if you implement an intervention or an aspect of an intervention, doesn't necessarily mean it will be the drug associated with it. And then with the, yeah, so those would be two different processes. So the essential medicine list is separate from the benefit package as well. So those are two different processes. For the cost effectiveness threshold, ideally a country should have its own threshold, but it's a very resource intensive study or process to generate the threshold. So that's why we usually tend to defer to what's been recommended, but the ideal is for each country to have its own. I think there are a few that have done that and they have their own thresholds. That would be ideal. So if the ISA is low, then that would mean that the drug would be, all the drugs with ISA that are lower than the threshold would be implemented. So again, that a piece of information is not the only one used for the decision. So you have to look at the criteria. So back to the criteria of the country. So you remember we had talked about, what was it, the financial catastrophe, the effectiveness, the population coverage. So you look at that criteria and make that decision. Yeah. And then to your question, so is there a metric for the criteria that you use? So I don't know if anyone has done work on that, because that would then be like a multi-criteria framework where you're able to base your decision on. So anyone in the room who has done work on that?
So we have a session on Tuesday. I'm from Ethiopia. I'm here as an African CDC staff, but I'm also Ethiopian. So we've done work in revising the health insurance benefits package for Ethiopia. And we used multiple criteria, of which cost effectiveness is one, equity is another, financial risk protection. And so we have a session, organized session on Tuesday morning to basically share our experiences on how we evaluated each intervention against those criteria and so on, what approach we used. So I cordially invite you to join us on Tuesday morning.
So there is a metric. So join their session on Tuesday. So this side, then we'll come to this side. Yeah.
Thank you for your nice presentation. My name is Dr. Rashid Mahmoud. I'm working as an academic health economist at the University of Sydney, Australia. We are introducing this the couple of the clinical trial to improve the diagnostic performance through the precision medicine technology, including the Carlex biopsy. This one is the new biopsy to introduce in terms of the performing better diagnostic. In this trial has used a couple of different precision medicine technology. The patient may be stratified with this small group. All of the patient will not offer for this particular diagnostic test. In terms of the assessment, it may be affect the uncertain of estimate. Is there any recommendation in this Thai HTA process? Is there any recommendation regarding this uncertain of estimate, or anyone can help to me just for the how we can incorporate this HTA process in terms of the uncertain estimate?
So that basically speaks to a clinical trial and sort of doing a cost effectiveness or cost utility alongside that, right? So I mean, with clinical trials, it's not the norm or the normal practice if you're implementing an intervention, right? So you need to make adjustments for different uncertainties as well, because the trial is an ideal situation where you have everything. But in most cases in the health system, there are a lot of missing pieces, right? So with the HTA process, I think it would depend on your analysis. So as you're doing the cost effectiveness analysis, just being clear on what parameters were included, whether it's in the costing analysis and in the effectiveness analysis as well. And then also being able to do what we call a sensitivity analysis, and you vary those parameters. So when you do the sensitivity, you could vary the parameters based on a real life situation. So the actual population coverage that will inform, that will have an impact, that the intervention will have an impact on. And then you also look at the outcomes as well based on that scenario. So these, you could always conduct a sensitivity analysis that could sort of give a real world picture of a new intervention. Yeah. Do we have any? Okay.
Hi, my name is Jumana. I'm from United Arab Emirates. There is a good book released by University of Oxford. It's about health economics modeling and clinical trials. And as you just mentioned about the sensitivity and the specificity analysis, so that might be helpful in your case. That's it. I can give you the name of the book once we are done.
Sure. Perfect. I think we had one that side, then we come to this side, or
one, then have two on this side.
Okay, we can have the two on this side and then go back to that side.
Am I? Okay. Thank you for your presentation. My name is Yeji and I'm from Monash University, Australia. I was wondering if you could explain more about negotiation process, because you mentioned that if the price of drug is too expensive, you can make it the price decrease to make it cost effective. And I wonder how the negotiation process goes in real life and who pays the gap between the original price or to a cheaper price? Thank you.
Okay, so you can take the two questions and I come back to that.
Okay, thank you very much for your nice presentation. My name is Daniel and I'm from Australia. I guess my question is around topic selection, and you rightly mentioned that we need to be more inclusive of different stakeholders. And to my understanding, you mentioned a lot of different stakeholders, and to my understanding, there's an inherent potential conflicts of interest among stakeholders. And this have its own ramification and influence on the overall decision, not only on topic selection, but it's, I think, cross-cutting across the whole steps. I guess my question is, what guiding principles or rules of engagement can be established to manage this potential conflict of interest, not only on topic selection, but across all the steps? And I think more broadly, what does the political economy has shape and influence each steps of HTA, and what can we do about it to mitigate its potential effects? Thank you.
Yes, please go ahead.
I'm Kabir Ahmad. I am from Bangladesh, but I came from Australia now, and I'm working for the University of Southern Queensland, Australia. My question is also related with topic selection. In fact, you presented nicely about the drug defined drug trial implementation and its stated decision that which drug would be better. But I'm wondering that if we go for health technology intervention, for example, usual other than health intervention, we go for digital health services among some rural areas or among some recipients. So then which criteria or on which basis we should decide that the digital health intervention is working better or cost effectively working? You said as an example here, then I see here, but for digital health technology implementation or intervention, what other parameters should we consider for health effectiveness comparison?
Okay, so let me just take those ones first. Okay. So let me start with the guidelines, and based on the conflict of interest, how then you can mitigate that. So with most countries that have implemented HTA, they tend to have a methods and process guidelines, right? So the methods will outline how exactly the assessments should be done and the different parameters. Then you have the process guidelines, which looks at the governance structures as well, the timeliness of the different steps, who will be involved, so on and so forth. So within, an example is like the Philippines with their process guidelines, they have like guiding principles on that abroad that would guide, for instance, the issue on conflict of interest. So some of the things that they look at is like the ethics, so the ethical soundness of that assessment you're doing, or the intervention. I think it's a criteria of like around 7 points. So you could have a guideline that's agreed upon by the people or the people involved with the development of the HTA system. And this will look at maybe the ethics as well, the transparency of the process, the accountability, so who you hold accountable if things are not working, the timeliness of the process to ensure that, so you can have different principles that guide that. I think even Ghana has its own principles. In fact, Thailand has its own principles, so it's something that's arbitrary. Then the other question was on, we had two questions, right? Oh, that was it, yes. So for digital health interventions and the negotiation process. So on whether to implement a digital health intervention in a rural versus urban setting, I think, again, the cost would be different, number one, right? And even the effectiveness based on the population that's being impacted would be different. So I'll just still go back to the other criteria that you need to look at, like equity, the efficiency of implementing that thing, the financial implications. So you'd have a different set of criteria that's important to the country and base your decision against that. Yeah, in addition to the information on the cost effectiveness. Then the other question on the negotiation process, I'm not entirely sure of the details of the process itself, but basically it would be a back and forth between the industry and the government. So when it comes to Thailand, so once they have generated their evidence and they say that this price, if you reduce to this price, the ISA reduces, meaning it makes it more affordable. For the drug that they managed to reduce the prices, it was a back and forth process over a period of time, up to the point where they were able to agree on a price point. So of course that wasn't the first price point, but it was, it's like an arbitrary process. Yes. So now in the afternoon sessions, and I think that leads, there was a question about industry and how that conflicts with their, interests. I think we'll speak a bit about that in the afternoon sessions, and maybe what has been found about the different case studies that have been looked at. Yeah.
Just to add to what she's saying. So for example, in the Thai team, I've just remembered a point that she's raised. So one of the things that they would do, so the farm, let's say the manufacturer or the industries submits a dossier and says, this is the price that this is what they want for the technology to be adopted. And as Angela has said, they will do the HTA process and then see whether it's cost effective or not, and the budget impact that it will have. If they see it's not cost effective, then they give the report back to the industry. And then the industries have a chance to look and see whether they can reduce the price. But also a negotiating factor would be, HITAP would tell them, listen, if you reduce to this much, it will be absorbed in the UHC scheme, which covers 90% of the population. So then they see, okay, if we'll be able to cover 90% of the population with this at this lower price, then we'd rather our product is absorbed. So then they reduce. So that's how they negotiate. Yeah.
No, just to say that Thailand domestically manufactures a lot of the drugs that you saw up on the list, which alters, I think, dramatically the cost negotiations.
Thailand, the UHC scheme, they don't give branded drugs. That is in the UHC scheme, because they have this civil servant scheme and the other scheme, which is for this thing workers. They allow to a certain extent, but in the UHC scheme, they go for generic. So generally, the prices are less, and most of it manufactured in Thailand.
Thank you. Thank you for those comments.
Yeah, thank you very much. My name is Emmanuel. I'm from Ethiopian Health Insurance Service. So I have one question on the use of cost effectiveness analysis and budget impact. So when you say an intervention is cost effective, we are like saying we will buy this much health with X amount of budget. That means when you say an intervention is cost effective, we'll have certain amount of health benefits, and there is a budget impact to provide that intervention. So when I see the previous presentation, cost effectiveness is one criteria, and then it goes to, budget impact.
Yes.
So what I'm thinking is, if an intervention is cost effective, then we are saying that the opportunity cost of not providing that services, it's budget impact analysis. So the way we are going to use budget impact after cost effectiveness analysis should be for price negotiation and so on. That means we may not be re-evaluating budget impact after we say it is cost effective, because cost effectiveness by itself is informing the budget impact of our intervention. So my question is it the same principle that's being applied there, or is there a situation where an intervention can be cost effective and they say, okay, this budget is so high, so we are going to leave it? Yeah, this is my question.
Yes, okay, just one more question.
Finally, it's my turn. Okay, I'm Yali Yang from Oxford University. Probably not questions, but several kind of like shameless advertisements. In Oxford, we're running a course, kind of short course of economic evaluation alongside clinical trials. If people are interested, they can register for that one. And also I'm co-leading a module as part of the master program called Translational Healthcare Sciences. In that master program, we have a module called Economics and Regulation for Translation Healthcare. So we are running this module in November this year. For that teaching, we kind of use a lot of principles and guidance and examples from the advanced, developed country. But I really want to bring some of the international global flavor to my module. So if people in this room, I know that people are interested in HTA. So if you're from different country and your country is trying to get into the HTA process, whatever the stages are, whether you're in the early stage of HTA or you have done a lot and to try to establish the process HTA in your country, if you're interested in sharing your experience of HTA in your country and interested in kind of get involved in delivering a section with other people, like, 50 minutes presentation with Q&A for my module, please come to me and we can talk. Thank you. And sorry for abusing this opportunity.
No, I think it's a good opportunity. I mean, the workshop is a learning experience, so it's good to know.
So
what
in the
people can
interest
do.
of time,
We can
kindly, we will
have
just check.
One more online question that ties to the question that
Yeah,
was
17
asked,
minutes past.
and then we'll move ahead.
So kindly, you bear with us, but we are open to questions while we are taking lunch.
Okay, so with your question on the opportunity cost, so the next session is introducing economic evaluations. So I think your question will be answered in the next session. So just hold on for a bit. Then I'll just, for the online questions, because we are behind on time, I think I'll read them out if we have time after her session, so that you can all hear what is being asked, and maybe we might have some responses, but they largely tie to whether we can use cost benefit analysis versus cost effectiveness in a HTA process, amongst others. So thank you very much for your participation, the numerous questions, the learning points as well. I'll hand it over to our next presenter for the next session before we break for lunch.
A round of applause. She points new slides. Yeah, those are the ones. Okay.
All right, so we'll move on to the next session. My name is Stacey Orangi, and I'm from Kemri Wellcome Trust as well. So this session, we look at the application of specifically economic evaluation to HTA, and just have an introduction, which might answer some of the questions that have come up in the previous sessions. So when we speak about, this concept has been brought about in previous sessions. So as we all know, healthcare resources are scarce, and we have healthcare needs that are that are unlimited, but we have to make choices. And so that's our biggest economic problem. And decisions have to be made. And I think this quote by Scalfa and Drummond illustrate the difficult process of doing decision making. And they say that the appropriate way to judge economic evaluations is not whether they embody some ultimate truth, but whether they lead to a better decision than would have been made in their absence. And so the rationale is that the essential goal of a health system is to improve the health population because we need to prevent early deaths. We need to have better quality of life and have a more equitable distribution. However, as we've previously mentioned, resources are limited in relation to the ever increasing and unlimited demands over time because we have an increasing aging population. And in most cases, we have new and more expensive medical technology, and we need to increase consumer awareness. So prior to doing economic evaluations, we also have to make some considerations. For instance, is the intervention on new technology safe? Because if it's not, then we would not even be considering economic evaluations. Is it available and accessible to the people who could benefit from it? So for instance, before the COVID vaccine was developed, we couldn't even proceed to do an economic evaluation before they are actually available. So some access availability is a key consideration. Efficacy, can it work under ideal or controlled settings? But even more importantly, can it work in normal or the real world situation? So coming specifically to economic evaluation as a tool to assess in HTA, it's basically the comparative analysis of alternative course of actions in terms of both the costs and the effectiveness or the consequences. And the diagram below simplifies what that would mean. So we have two choices. We need to decide if you're going to invest in program A or program B, and we look at the costs of both and the effects or consequences of both, and then we need to have a decision based on that. So why we do economic evaluation? So as mentioned, we have a scarcity of resources. We have to have a tool to assist us to choose between different options because decisions have to be made. And as we make these decisions, we need to improve on efficiency in terms of who should get what and with what healthcare resources in relation to other uses of those healthcare resources. And so the first thing we consider in economic evaluations are costs. So costs, just a brief definition. So we have financial costs. So those are the actual expenditures on goods and services purchased. On the other hand, we can go a step further and consider economic costs, which estimate the value of goods and services for which there are no financial transactions. So for instance, let me use the COVID-19 vaccines. In low and middle income countries, initially, some of the COVID-19 vaccines were donated through bilateral negotiations in the initial stages. And when you're doing an economic evaluation, if we look at financial costs to the payer, we'd not consider the costs of those donated vaccines. But if we look at the economic costs, we'd have to place a value for those donated vaccines or any volunteer time. And this is because we have a something called opportunity costs. And this is the value of the highest value alternative health interventions or the opportunity that is forgone. So for instance, we are all seated in this room attending this session, but we could have been elsewhere. We could have been in another session or spent time doing another activity. So the opportunity cost of you being here is the value of what you're foregoing in order to be here. So we also have to consider opportunity costs in our economic evaluations. Another thing to consider while doing economic evaluations is the perspective. So when we look at costs, we can take a societal perspective and look at all the costs that have been incurred by all actors involved in providing or using a service. And we'll get into more details on that. So for instance, if we're using a societal perspective, we can not only look at the provider's costs, but also the patient costs, or even go a step further and look at costs from other sectors that affect that intervention. Provider costs are simply the costs incurred by the provider of the specific service or drug. And then we also have households or patient perspectives, and those are the costs incurred by the patients in the process of seeking and consuming healthcare. We'll get into a bit more practical examples ahead. We also need to look at the consequences or outcomes in the health. And the outcomes can be assessed in several different ways. We can express the outcomes in terms of natural units. Earlier on, there was a question on whether we could do economic evaluation comparing drugs within the same disease area or across different disease areas. So when we compare outcomes in natural units, most times that's in the case where it's within the same disease area, and we can look at the cases treated or life saved, life years gained, or pain-free or symptom-free days. We can also look at the outcomes based on the preferences based on health. That's multi-dimensional, for instance, using QALYs, which is quality adjusted life years or disability adjusted life years. And that can help us compare interventions across disease area because we are sort of standardizing the outcomes. We can also compare outcomes by expressing them in monetary terms for the purposes of cost-benefit analysis. And so based on how we value outcomes, we can have different types of economic evaluations, the first 5 listed. So we can just look at the costs and have a cost analysis, or do a cost-benefit analysis or a cost-effectiveness analysis that's largely referred to, cost-utility analysis, cost minimization analysis. And once you do those economic evaluation, you can then go a step further and look what the budget impact is. So looking at a cost-benefit analysis, it aims to determine whether the benefit of the health program exceeds the cost. And in cost-benefit analysis, we assign a monetary value to the outcome. So it's useful, as mentioned, for comparing programs across different sectors. So if you have an intervention in the health sector and we want to compare investing in it versus another intervention in the education sector, a cost-benefit analysis can be useful in helping us decide that. And how we go about assigning monetary values to the outcome, there are different approaches, including using a human capital approach, where we look at the increased productivity in the marketplace. We can also seek to find out what the revealed preferences are from the population, or also use a contingent valuation approach, for instance, a willingness to pay to value our outcomes. The cost effectiveness analysis, in this case, our outcomes are measured in units relevant to the intervention. So as mentioned, if you're comparing 2 interventions in the cancer care, we can look at the number of cases detected. And this is useful for the decision-making, who is considering options within a certain field. So if your interventions are within the same field. And the cost effectiveness analysis is therefore not useful in comparing different types of interventions across different diseases. And that's where the cost utility analysis comes in. So for the cost utility analysis, we transform the disease-specific outcomes into generic measures by combining quality of life and life expectancy into one outcome. So that's why it enables us to compare across different areas. And the consequences are adjusted for health state preferences or utility scores. And I'll come to a practical example in a bit. And it's useful for cases where extension of life comes with drug side effects, and it compares the life years with an assessment of the quality of life. And in some cases, we prefer to view cost utility analysis as a sub-case of cost effectiveness analysis. So this is just an example of how we'd go about getting an outcome measure. For instance, the quali. So we have Professor Pengo, who is 50 years old and HIV positive. His self-assessed quality of life is currently 0.2 utilities. So maybe just to mention, I said qualis, we need the quality of life, which most times is self-reported, and it ranges from 0 to 1. So 0 being death and 1 being perfect health. So Professor Pengo has been given a tool to assess how he feels his quality of life is, being HIV positive and not being treated. And he reports that his quality of life is about 0.2 utilities. If he is not treated, he will die in 5 years' time. If you were to receive this PAL omega treatment, his remaining life expectancy might rise to say 13 years, and his health-related quality of life would also increase to 0.75 utilities. So when we're measuring or calculating the quali, basically what we do is we multiply the quality of life by the expected life years. So for instance, the qualis assigned to treatment option A, where he receives the PAL omega treatment, would be the remaining life years of 13 years by the quality of life, 0.75 utilities, and we get 9.75 qualis. If he was not to get any treatment, the qualis assigned to that would be 1, and therefore the gain of the intervention is the difference, and that's 8.75 qualis. And just to tie that to the example Angela brought earlier for qualis, for incremental cost effectiveness ratio, if we are to put a cost to the treatment of intervention A and B, we find that when we subtract the cost and divide that by the difference in effects, then we get the incremental cost effectiveness ratio is 2,285 euros per quali gained in this case. The other economic evaluation you could consider is a cost minimization analysis, and it's used when alternative interventions have similar outcomes, and the objective is to find the least costly intervention. And this method has limited application. This method has limited application because it is very rare to find interventions that have similar outcomes. There was a question earlier on budget impact analysis, and I think this would provide a better description of why we do an economic evaluation versus a budget impact analysis. So a budget impact analysis most times comes after the economic evaluation, and it's used for budget planning and forecasting and estimating the budget holders' affordability. So for instance, we could have done a cost effectiveness analysis, and we have determined if the intervention is good value for money. So the question we're addressing is, do we allocate resources to this intervention? And let's say we found it to be cost effective. Then we can go a step further and do a budget impact to understand, is it affordable to the payer in terms of, and that would help them budget and forecast the intervention that either is to be included in the benefit package in the case of newer interventions. So basically this table summarizes the different economic evaluations that you can consider. As you will in all of the interventions, you need to consider costs as well as outcomes. The way you value outcomes is what would determine what type of evaluation you're doing. If you're not considering outcomes, that's a cost analysis. If you are looking at the cost effectiveness analysis, then you will value your outcomes using natural units. And that's where you have a single effect of interest common to both alternatives. Cost utility can be used across different interventions. Even if the outcome is not common, and you can use healthy years. And a cost benefit analysis is where now you look at both the costs and outcomes in monetary value. So basically, I want us to illustrate the key components of an economic evaluation. So this is, imagine you're a director of a HIV program in your country's Ministry of Health, and your country is considering changing the drugs that are provided to prevent mother-to-child transmission. So the current regimen is nevirapine, provided to the mother and baby at birth, but you want to consider a new regimen, which is zidovudine, provided at the 28th week of pregnancy, together with the nevirapine to the mother and baby at birth. So your outcomes are that the current regimen prevents about 14% of the potential transmission of HIV to the mother and baby, and the proposed regimen will prevent about 21% of these cases. How can economic evaluation help you to think through the pros and cons of each strategy? So this is just a summary of what you may need to consider. So at the top, you need to consider all the resources that would go to each of the interventions. Resources from the health sector, other sectors, from the patient side, and productivity losses. And that is informed by the perspective that you take. Are you taking a provider's perspective, a patient's perspective, or a societal perspective that would need to consider all those resources? Then you have your healthcare program, and you also need to look at the outcomes in blue. You can also look at the other value created from your interventions and the resources saved. So specifically looking at the healthcare resources, for that case in HIV prevention, you need to look at the quantities of drugs used, for instance, in both cases, the equipment, the days in hospital, the doctor's visits. You need to consider all the various inputs that go into both treatments in terms of quantities, and then multiply that by the respective prices. You can also consider other sector costs. So if you're using a societal perspective and your intervention caters or touches on other sectors. So let's say in the HIV case, there's involvement of the social protection sector, because you have social workers, for instance, involved in that intervention. So you need to consider those costs as well. You can also consider the patient costs, travel time, and costs to get to seek the services that they're coming to seek, as well as the time costs. You should also look at productivity costs or productivity losses by considering the lost time to seek care from work. You then look at your outcomes in terms of what is the improved health. If you're doing a cost effectiveness analysis, that can be measured in natural units. But if you're considering, for instance, a cost utility analysis, that needs to be valued as health utility, so either QALYs or DALYs. Then if you're doing a cost benefit analysis, you need to value your outcomes in terms of monetary terms, and that could include all or some consequences. So how much would you be willing to pay in relation to increased taxes to gain X health outcome? So that's just an example of how you would try and elicit a willingness to pay from people who are receiving the intervention. In terms of other values created, you can also look at the value of information or the value of reassurance, but there's a lot of debate in literature in considering this aspect in economic evaluation. So in most cases, it's usually left out. In terms of resources saved, this comes about, you need to also be aware of what the costs averted from choosing intervention A instead of BR. And therefore, you might be wondering, we've talked about the 5 different economic evaluations. Which one do you choose when you're wanting to do your analysis? So we find that economists favor cost-benefit analysis as it's consistent with welfare economics and it can establish the net benefit of a program. However, the drawback with cost-benefit analysis is the available methods in assigning monetary values to the outcomes are highly contentious. And so we find a lot of people opting for cost utility or cost effectiveness analysis. And that has seen increasing demand from governments and other funders in using those methods. And so when we are making decisions, when it comes to economic evaluation, it provides valuable inputs to decision making, but it's particularly important to ensure that when we're doing these studies, to look at what the full costs are and what the full outcomes are. We also need to be transparent about what our trade-offs are. But as we have discussed previously, what will actually be taken is also, we need to have political considerations because we have the results, but there's a lot of political considerations that go into these processes. So this is just an illustration on cost effectiveness threshold. So you might have your ISA and you want to find out, do you take the intervention or not? So in this case, we're looking at 2 drugs or 2 causes of regimens of treatment where you have HIV care. You're looking at first-line antiretroviral therapy against first-line and second-line antiretroviral therapy. So this graph usually helps us to decide, or it's a good visual representation of knowing whether you should adopt something. So if something falls in this quadrant, it's more costly. So what is at the point 0 is the comparator or the standard care. And you find that your interventions ISA lies somewhere here, meaning it's more costly, but less effective than the standard care. What do you think we should do? Yes, more costly and less effective. And what the Kazungu? There's feedback, and maybe you can first introduce yourself and tell us where you're from.
I am Asma from Egypt. In this case, we reject the new intervention because this is dominated by the standard one. It offers highly cost at lower efficacy.
Yes, great. And if you do compare the cost and it falls within, the ISA falls within this quadrant where it's more effective, but less costly. What do we do?
Yeah, I was saying if it is in that quadrant, we can just go ahead with that option.
Yes. So if it's in these 2 quadrants, we don't even consider the threshold. It's almost intuitive what we should do, right? But then if it's in either of these 2 quadrants, then it becomes more difficult to know whether to adopt it or not. So if it's more costly and more effective, which is a large number of interventions fall there, or if it's the new treatment is less effective and less costly. So then it becomes a bit difficult, and that's why thresholds come in, which are basically the societal value to gain lives. And as Angela previously mentioned, if an intervention falls below the red line, that's the threshold, then we can recommend for adoption of the intervention. However, if it falls above, it's not cost effective. A good way to also present your results is you find that you have a point estimate of an ISA, but when you do sensitivity analysis, you might find if you vary different values or parameters, you could find that you would see that the intervention might fall maybe on this quadrant or sometimes on this quadrant. So it informs how certain you are that your intervention is cost effective or not. Because if you do the sensitivity analysis, sometimes it might fall above, but you might find it's only maybe 2% uncertainty that it's not cost effective. So that's the importance also of doing sensitivity analysis. So thresholds, as mentioned, is a societal value of living longer and healthier lives. In some countries, especially higher income countries, there's an explicit policy on what the country uses as a threshold. However, in a lot of the developing world, there's no threshold policy. And most times we've been using the WHO recommendations of if it's 2 times the GDP per capita, it's very cost effective, or if it's 3 times the GDP per capita, it's not cost effective. And as Angela has said previously, for instance, there's also recommendations currently of using half of the GDP per capita in low and middle income settings. And some of the criticisms of the WHO approach is that it's unlikely that a one-size-fits-all threshold is sensible. So what's being used as a threshold in a higher income country could also apply in a lower income. So that's one of the criticism of using a standard threshold across different settings. And it's a value, so it probably differs depending on the burden of disease of the setting, the severity of the disease, and the characteristics of the population. And so that's why I think some newer literature that recommends about the 50% of the GDP per capita came in. So just to echo what has been said before, we have the evidence from economic evaluation, but that doesn't form the sole criteria for decision making. There are other factors, and this is just to mention a few that the country can list that needs to be considered. So for instance, the size of the health issue or the burden of the disease compared to rare conditions could be a factor. Ethics, equity, feasibility and sustainability, acceptability to stakeholders, such as are they willing to discontinue the current practice and adopt the new recommended treatment, and political consideration based on what's in the global versus local agenda. And this is just a quote that highlights, for instance, why other considerations and not just looking at cost effectiveness analysis. So for instance, if you look at equity issues, there's a quote that says, no country is interested in efficiency alone, which is what economic evaluations look at. If countries just used the efficiency criteria alone, many low birth weight children would be left to die. So that's why you need to make trade-offs, but also be explicit on the trade-offs that you're making. So in conclusion, decisions have to be made, and the appropriate way to judge economic evaluations is not whether they embody the ultimate truth, because there are other considerations that need to come into play, but they can lead us to a better decision that would have been made in the absence. So economic evaluations is not, they don't embody the ultimate truth, but they lead us to a better decision than what would have been made in the absence. So thank you. So maybe I can take a few questions.
Another round of applause first. So, in the interest of time, we'll give priority to those who have not asked. Yes.
I have a very small question. So you mentioned about 50% GDP per capita threshold. May I know the reference, please, if you have? Thank you.
Yes, I can share with you a paper that outlines that after this session.
Hi. So you mentioned about the threshold setting. So I'd like to know, like, if it's like a universal for all the diseases, all the programmable intervention, or why is not disease specific or like each program specific?
Okay. So I'd briefly say that a threshold is the societal value that is placed on saving lives. And that is a standard value, I'd say, across different diseases. And it makes us be able to compare across different, because you'd be, as a policymaker, you'd face situations where you're not only looking at, for instance, hypertension as a treatment, and having this one metric, if you're comparing hypertension versus diabetes, helps us to be able to make fair comparisons. Yeah. Yeah, you can go ahead.
Thank you very much. I just want to thank you for the presentation. I have this question on the relationship between, cost effectiveness threshold and budget impact analysis. Now, conceptually, when you say an intervention is cost effective for a given country, that country is saying, I can afford this intervention if it comes to my country. So basically what they are saying is, for a given budget that's going to be allocated for this intervention, what we are saying is, if that intervention is cost effective, we are talking about affordability. The value of the money is somehow talking about the affordability issue. And what I do not agree personally with is, we should not be like separating cost effectiveness threshold from the concept of budget impact analysis. And I know there are a lot of debate with relationship to, related to these issues, but I think this gap should be reduced. And if any country have an intervention which they say it is cost effective, but they at the end they said, I cannot afford this, that means we have a question with their threshold. That means their threshold is not right. This is the implicit message that the threshold and this budget impact analysis have. Maybe I would like to see your comment on this. Thank you.
That's an interesting one. And maybe, is it related to what he said? Yeah. Or it's different? Okay, let's give you a chance.
Okay, I'm Richmond Owusu from Ghana. So with what my brother is talking about, I think that again, yeah, cost effectiveness and economic evaluation is talking about affordability. And we are also interested in working from the perspective of economic cost. When it comes to budget impact, we are looking at financial impact on the country's budget, and it takes into consideration financial sustainability beyond, okay, we can, I mean, this gives value for money, but in the next 10 years, is this something we can sustain financial? That is what I also think. Thank you.
Yeah, I think that's a good point. So although the cost effectiveness analysis has established that this is good value for money, are we, it's good value for money, but we already have things that we are funding. We need to make trade-offs and be clear on what the budget is in the long term. Is it sustainable moving forward? And those are the nitty-gritties that the budget impact analysis also looks at. So even if it's cost effective, we need to ensure that we are able to make sure that we are able to finance it in the longer term, and hence the budget impact analysis. But as you said, I think they need to go hand in hand. Yeah. There's okay, let me give you a chance.
Okay, I just looking at, I agree with the two scenarios that you look at cost effectiveness, and sometimes the cost may not be maintained over the period. And so it's better to do what is in the middle. For the case of some countries like Liberia, I'll give you a practical example in a village where the lady had two kids and they were suffering from malaria. And there's a normal dose for malaria, but she had to split the tablets to give each person half, and then the next day half, just like that. So another one is where someone sent clothes for the child, and she found out there were two children. So one person wear the shirt, and the other person wear the trouser in the village. So there's a way of solving this situation, particularly with countries like developing countries that doesn't have the efficiency in measuring all of this, and wouldn't depend on national budget, which is not very substantive. So yes, efficiency is okay, but if there are less funds, particularly donor driven, where there's donor weakness, then you have to just take the median or the mean.
And I think what he's bringing out is HTA helps us to have explicit ways of making decisions, but we do find in the absence, we still have decisions being made, but through more implicit ways. But I think it's better to have an explicit way of how we make decisions. We can go to, okay.
Just a comment on the threshold across different diseases.
Yeah.
So the threshold is basically a reference value for decision making across the boundary of the conditions or diseases. However, there is more and more conversation about whether we need to consider a different threshold for a group of conditions, like for example, the rare diseases, because the nature of the disease itself is different from the rest of, for example, the chronic diseases, and also the population size impact by the HTA for either treatment or whatever intervention for the rare conditions is different. It's so small. So there is more and more conversation about whether we should set a higher threshold for the rare diseases. And there's a definition of rare disease. So NICE is, I think, in the process or has some indicative guideline about, maybe a higher threshold should be applied. That's just a comment from me.
That's a very good comment. Thank you for that. There's hand up. The two of them.
Hi, I'm Emily Myers from Vital Strategies in the US. And I had a question about, I was wondering what you think about the usefulness and the feasibility of explicit methods for incorporating equity into cost effectiveness analysis, like extended cost effectiveness analysis or doing economic evaluation with subgroup analysis, and whether you see that being used in practice. Thanks.
That's a good question. And I want to shelve it for tomorrow.
Yes.
Because there's a whole session on equity analysis. But say that again. Okay.
Yeah, just one
Just
quick.
let her just keep in relation to that, and then we can move on.
Something. Yeah, just to add what she said, like other than even in rare diseases, but we have certain conditions in common diseases like multi-drug resistant tuberculosis, or where even when TB is common, but still drug resistant tuberculosis, then even the malaria, certain disease, the cost is very high to treat certain cases. So going by HTA, it doesn't facilitate that kind of thing. So we have to have the equity and the threat posed to the society as well. Like even one case of certain disease we consider as epidemic. So then there are certain issues.
So we also need to consider other factors.
Yeah, so extended cost effectiveness analysis, as the name implies, is an extension of the standard cost effectiveness analysis. So it basically brings two important additional dimensions to the standard cost effectiveness analysis. One is equity. As you said, basically you get the outcomes stratified by, could be economic quintiles, or you could also use it for geography and other stratifying variables of importance for equity considerations. But the other important dimension it brings is financial risk protection. So basically can help you assess an intervention in terms of how much per investment, how much financial risk protection gain, which could be measured in different ways. Could be poverty cases averted by investing in a certain investment in an intervention, or catastrophic expenditure cases averted. And so ideally what you would like to have is you do extended cost effectiveness analysis of list of intervention that you are considering for inclusion in the benefits package, or if it's individual cases, then you do that analysis and then compare them just like you do for CA based on the return on investment in these two other additional dimensions, and then find a way to merge them, which is another whole lot of issue. But yeah, so it's the ECA approach is getting more and more attention, but it's not yet widely applied in terms of actually guiding decisions. But we are, some of us, my colleague Lisa and myself, I think, yeah, we have done some work in that field, and we're trying to introduce the ECA into this space. And hopefully, if you come a couple of years later, we'll have said, yes, we have.
Thank you for that.
Thank you. In terms of this, the Emily question, and just I would like to add just a little bit, just for the 10 cents in here. In terms of equity consideration, the one of this the approach is, it's called this the distributional cost effectiveness analysis. And this cost effectiveness analysis, it may be more helpful to address this the equity issue. Thank you.
Thank you for that addition. There's a question on this end.
Please don't chase me away from the table at lunch when I don't give you the mic.
Thank you for your nice presentation. In fact, it's not a question, it's sort of seeking help or suggestion. And I got to learn about the budget impact analysis here in more detail. So, but I was wondering about cost consequences analysis, so about the economic evaluation. So one of my collaborators wanted to work on that. So from you or from anyone from this session, can anyone please explain a bit what is the comparative advantage of or disadvantage of the cost consequences analysis?
Okay. Do we have any?
Thank you. My name is Soyad Afroz Karaman. I'm a postdoctoral research fellow at the University of Queensland, Australia. So I'd like to say something regarding the questioners of Kabir Ahmed. So basically your question is regarding, you would like to know something about cost consequence analysis, right? Well, so what she have presented about five economic evaluation, 5 types of economic evaluation. So all these sort of economic evaluation basically start with on health benefits of the intervention. But in reality, an intervention has multiple health benefits. So when we consider or taking into account multiple health benefits, then we will go for cost consequence analysis. And in cost consequence analysis, we don't give you a ICER value. So regarding, we present the health benefits in disaggregated form so that policymaker can take decision on the health intervention. Thank you.
Thank you very much.
So with that, I think we can start. Thanks. But I think there will be snack around 3 p.m. So at least that's a makeup. You can go grab snack at 3. So you have about less than an hour to 3. So I'll hand this over to Rehab. Thanks. Okay.
All right. Thank you and welcome back. I'll take you through this session where we'll be talking about factors that influence institutionalization of health technology assessment at the macro level, so at the national level. And this was based on our literature review. So the outline of this presentation, I'll start with an introduction. I'll discuss the methods that we used for this review, and then we'll discuss the findings, and I'll provide policy and research implications of this work. So in the morning, we talked about health technology assessment, and we defined it, and we said that it's a multidisciplinary approach for explicit priority setting in healthcare. We also said, or I hope it came across from the morning presentations, that it studies the economic, medical, social, ethical, and legal implications of health technologies. And also in the group, we had someone giving us examples of health technologies, and this include drugs, medical devices, and surgical procedures, among others. This is just a small list. So there's a growing interest in institutionalizing HTA. And maybe now I just want to ask in the room, who knows what institutionalization means? Or what's your understanding of institutionalization? This. Kindly tell us your name and where you're from.
Okay, okay. I'm Ahmed Siam. I'm from the Universal Health Insurance Authority in Egypt. I think institutionalization means having like a formal process and formal institutions that manage any kind of process whatsoever. So.
Okay, that's one way of looking at it. Anyone else with?
I'm Aishiru Abubakar from Nigeria. Maybe the other adjective, so to say, to put is making it routine part of the work done by government for whatever they want to do. Then let's do the HTA, just make it part of the system.
Right. Okay, great. Thank you. Any other views?
This side,
Okay, great. So as has been mentioned by the two colleagues, institutionalization means establishing, so for example, HTA as a normative practice. So it should be a routine way of doing things. And as you've mentioned, it requires institutional and organizational arrangements to support that process. So we find that there are more high and upper and middle income countries that have institutionalized HTA than low and lower middle income countries. So we were curious and we wanted to find out, what are the factors that influence institutionalization of HTA at the national level across countries from different contexts. So this is what laid the foundation for this work. So we used, we conducted a scoping literature review, and we used the HTA anomaly framework. In the first step, we formulated the research question, which I've just mentioned. Then in the second step, we identified relevant literature. And here we looked at several databases. So we used PubMed, Embase, Sino, Scopus, Econlit, and Google Scholar. And then the key search words were related to institutionalization, health technology assessment, and the national level. From this, we found numerous literature. So we had to select studies that were relevant, and the inclusion criteria was that they needed to be empirical studies that were peer reviewed with full access, but we did not impose a date limitation. And we used the CASP tool to appraise the quality. Then we used the thematic analysis to identify the key themes, and then we synthesized and produced a report. So we found that there were several factors that influence institutionalization of HTA. And the first thematic group was organizational resources for HTA. And here, as one colleague has mentioned, there was establishment of organizational structures for HTA. So this include HTA agencies, commissions, offices, and research centers, which can either be based at the ministry or outside, so in academic organizations. So we found that there were more high and upper middle income countries that have organizational structures for HTA than low and lower middle income countries. And how did this influence? So for the organizations that had, for the countries, that had organizational structures for HTA, how did this influence institutionalization? So we found that it expanded the organizational capacities, either of governments or ministries of health, to conduct the HTA process. These organizational structures, some of them developed standardized and disseminated HTA process and methods guidelines. And as Angela mentioned, these are important in guiding how the process is conducted. Then thirdly, some of these organizations conducted HTA awareness and capacity building initiatives. And lastly, they maintained repositories of HTA outputs so that purchasers in the country can have access to them and use them in informing decision-making. The second organizational factor that influenced institutionalization of HTA was skilled human resource for HTA. And what do we mean by skilled human resource for HTA? So these are individuals with the technical capacity and the competence required for HTA. And I would just want to ask in the room, what do you think are some of the technical capacities required to enable a HTA process? Some of them might have come across, like they might have been mentioned in the morning. In the room? Okay, modeling skills. Any other skills, technical skills, or skilled human resource that we, okay. So some of the technical skills that we need would be, for example, in health economics, so that we're able to do modeling, we're able to do cost effectiveness analysis, things like that. Another skill would be evidence synthesis. So we might not necessarily have readily available literature, primary data, but we can conduct an evidence synthesis to obtain literature. We assume that many people can do a literature review or a meta-analysis, and it's not necessarily the case. We need epidemiologists, people who can tell us what's the burden of disease, things like that, among other skills. So we need individuals with the technical capacity for HTA. So we found that there was limited availability of skilled human resource globally, but more so in the low and lower middle income countries. So this unfortunately undermined institutionalization of HTA because, one, there was no capacity to conduct the HTA process. So you need the capacity to be able to conduct the HTA process. If you do not have skills if you don't have a health economist, you might not necessarily be able to do, a cost effectiveness analysis, which is part of the HTA process. It also undermined the perceived quality of the HTA process and output by policymakers. And you can imagine if the quality is perceived to be low, then there's less likelihood of HTA outputs being utilized in decision making. There was also, it also undermined capacity to adopt internationally generated HTA research. So there's the research out there, but can we actually interpret it and apply it in our local context? If we don't have the skills and the knowledge and the competency, we might not be able to. The third organizational factor was financial resources for HTA. And these financial resources came from internal sources such as the government or external sources. So it could be donors, it could be fees charged to manufacturers or other stakeholders who are submitting dossiers for the HTA process. So we found that there was limited availability of funding globally, but more so again in low-income countries and lower middle-income countries. So what was the influence of this? Limited availability of financial resources undermined institutionalization. So it was not possible to do HTA as a routine practice because we did not, literature showed that there were no organizational structures. So financial resources, limited financial resources undermined establishment of organizational structures for HTA. It also undermined the HTA process. It's, again, as we mentioned in the morning, it's a resource intensive process. And one of the resources it requires is funds. Then it also undermined HTA capacity building initiatives because also these ones require funds. And the third organizational resource was information resources for HTA. And this point also came across in the morning. One of the resources, as we said, HTA is resource intensive and it requires data. So HTA is data hungry. You need data to inform the HTA process. And some of the data that was mentioned was burden of disease. You need data on costs. You need data on effectiveness, feasibility, and safety. So you'll find, we found that this would either come from health information systems or databases. but the literature showed that there was limited availability of good quality data across countries globally. And this undermined the capacity to conduct HTA process. Without data, you cannot conduct the process. And it also undermined acceptability and utilization of HTA outputs, because the lack of data resources undermined the quality, which undermined the acceptability and utilization of HTA outputs. So the second thematic group, I've just talked about the first thematic group, which was organizational resources for HTA. So the second thematic group of factors that influenced institutionalization of HTA was legal frameworks, policies, and guidelines for HTA. So here we categorize this. The first factor here was legislation and policies on HTA. So these were available in the form of laws, ministerial decrees, parliamentary statements, and national strategies and frameworks and policies, health policies. We found that there was adequate availability of legislation and policies on HTA in high-income countries and upper-middle-income countries. And this legislation and policies created room or provided for the establishment of HTA agencies. They led to the utilization of HTA in policy making. And how did they do this? They actually outlined which policy decisions would be informed by HTA. So is it the development of a health benefit package? Is it the development of an essential medicines list, and so on and so forth? Then the third way in which the legislation and policies influenced institutionalization of HTA was it provided for the allocation of financial resources for HTA. So they clearly stipulated that a certain amount of budget would be allocated for financial resources for HTA. Then lastly, this legislation and policies in some countries allowed for national and international collaboration for HTA, and this supported institutionalization. And unfortunately, in low and lower middle income countries, we found that legislation and policies were not available. And so it failed to protect the process from political interference. It undermined utilization of HTA in policy making, and it also undermined introduction of capacity building initiatives. And this is based on the literature that we reviewed. And just to mention, which I didn't mention before, among the articles that we reviewed 77 papers, and 59 of these papers were from high and upper middle income countries, just to give you a context of how limited the literature is from low and lower middle income countries. And lower middle income countries. Then the second factor in this thematic group was the HTA guidelines. So this includes process and methods guidelines and decision-making frameworks. And some of these things were touched on by Angela and Stacy. So it's important to have process and methods guidelines to guide the HTA process. Without them, it can influence the HTA process. So we found that there was varying availability across countries. So for example, there was adequate availability, or there was availability of HTA guidelines and decision-making frameworks in high-income countries and upper middle-income countries. And this supported the capacity to conduct HTA processes. It led to standardization of HTA processes and utilization of HTA outputs in policymaking. Unfortunately, the opposite was found in low and lower middle income countries, where there was limited availability of process and methods guidelines, as well as decision-making frameworks. So, and this decision-making frameworks includes what we're talking about, the cost-effectiveness threshold. So we have limited availability, which undermine capacity to conduct HTA processes in low and lower middle income countries. It undermines standardization of the HTA process, and it also limited utilization of HTA outputs. The third thematic factor was learning and advocacy for HTA. So this was important for institutionalization. And under this, we had HTA capacity building initiatives. And some of the examples that were mentioned in literature included short-term and long-term initiatives. So short-term initiatives would be something like this. A one-day workshop, you know, a short course on HTA. And then long-term initiatives were undergraduate and postgraduate training in HTA, or in courses related to HTA. So we found that there was limited availability of capacity building initiatives globally, but again, more so in low and lower middle income countries. And this limited availability of skilled human resource for HTA, and it limited the understanding of the benefits of HTA by HTA doers and users. So doers would be people such as health economists, and then users would be policymakers. The second factor here was HTA awareness creation activities. And here we had examples such as conferences, seminars, and workshops. We found that there was adequate availability of HTA awareness creation activities in high-income countries and upper-middle-income countries. And this increased the visibility of the value of HTA in policymaking among stakeholders, and more so policymakers. It also led to a great understanding and acceptance of HTA among policy and decision makers. So you can see that HTA awareness is important in institutionalization of HTA. The fourth factor that we found was collaborative support for HTA. And here we had international collaboration. So this would occur through international HTA networks. I'm sure some of you have heard of the EU HTA network. You've heard of the Asia Link. There are several of them. So literature pointed that international networks such as those, and then others through political and economic unions, and global policy networks such as the International Decision Support Initiative played a key role in international collaboration for HTA. So we found in the literature that there was great collaboration internationally for HTA, particularly in high-income countries and middle-income countries. So this supported institutionalization of HTA in the following ways. There was increased availability of funding for HTA projects. It supported development of HTA policies. It supported HTA awareness creation and capacity building initiatives, and it also standardized HTA process and methods guidelines, which allowed for HTA processes to be conducted and the outputs to be absorbed. The second way in which international collaboration occurred was through the involvement of multilateral agencies and other organizations. So we found in the literature that World Bank, WHO, and PATH were involved in supporting institutionalization in several high, middle income and low income countries. So this again had supported institutionalization of HTA through establishment of organizational structures, funding of HTA projects, creation of databases for HTA, and then through provision of technical and financial support for HTA awareness and capacity building initiatives. Then the fifth factor, and some of this even were visible in the morning as we were talking in this discussion, but we also found this in literature, were stakeholder related factors. So this was a fifth thematic group of factors that influenced institutionalization of HTA. So the first stakeholder related factor was policy and decision makers awareness and understanding of the value of HTA. So we found that there was higher awareness and understanding in high and upper middle income countries. And this had resulted in more allocation of financial resources for HTA and support for establishment of organizational structures for HTA. Unfortunately, in the low and lower middle income countries, we found that there was limited awareness and understanding. So this undermined the demand for HTA. You need policymakers to be aware and then to create demand for HTA. So there was limited awareness, which undermined demand for HTA. It also undermined integration of HTA outputs in decision making. In some countries, it also undermined political support for the HTA capacity building activities. Then the second group of factors among stakeholder related factors was stakeholder interests. And this was very interesting actually, as we're reading the literature, to see this emerge and how this can influence institutionalization of HTA. So among this, stakeholder interests included policy and decision makers' interests. So here we found that stakeholder policymakers and decision makers' interests varied, and they included containing healthcare costs, interest in affordability of health technologies, interest in quality of care, interest in effectiveness of health technologies that are available, and also importantly, interest in UHC. So we found that where interests such as this existed, it supported institutionalization of HTA through establishment of organizational structures, allocation of financial resources, development of HTA legislation and policies, as well as HTA awareness creation and capacity building initiatives. Then we also found that health professionals' interests influenced institutionalization of HTA. And here we found that interests such as improving quality of care and objective allocation of health technologies led these stakeholders to support institutionalization through lobbying for introduction of HTA and supporting HTA awareness and capacity building initiatives. However, on the other hand, we found that health professionals were interested in safeguarding the autonomy of doctor-patient relationships. They wanted to be able to inform the decisions on patient care. And so they felt that, according to the literature, they felt that having HTA would minimize their autonomy, and therefore they opposed the use of HTA in decision-making. The third group of stakeholders whose interest was important in the institutionalization of HTA were patients and patient advocacy groups. And here, as you can imagine, their interests were having access to health technologies and again, in the autonomy of doctor-patient relationships. So they felt that the use of HTA would compromise access to health technologies and would also compromise autonomy of doctor-patient relationships. And so in some countries, it led to the opposition of the use of HTA in decision-making. Then we have HTA epistemic communities, and these are people who believe in the value of applying HTA in the decision-making process. So it can be people with the technical skills, or it can be people who are involved in similar processes. And we found that in the literature, HTA epistemic communities were interested in evidence-based solutions to resource allocation, and HTA is an approach to evidence-based priority setting. And therefore, based on this interest, in some countries, it supported institutionalization because they lobbied for HTA to be institutionalized. Then the fifth group were the manufacturers, industries, and other private sector organizations. So here we found that some were interested in transparency and accountability. They felt that using a HTA process would promote transparency in the decisions and even promote competition, according to the literature. And this led them to support the use of HTA in decision-making. On the other hand, it goes without saying, their interest in safeguarding pricing and profits and using HTA would provide a transparent way of informing this pricing. And they felt that using a HTA process would diminish the profit margin, especially, and this led to the opposition of HTA in decision-making. And so here we summarize the factors that we found that influence institutionalization of HTA. So if we're looking at HTA as a process to inform policy and decision-making in the health system, we find that organizational resources are important. Without organizational resources for HTA, we cannot institutionalize HTA. We found that legal frameworks, policies, and guidelines are important in institutionalization of HTA. Then we found the third thematic group of factors, learning and advocacy, were important in supporting institutionalization of HTA. Fourthly, stakeholder-related interests also matter. You can have organizations, you can have legal frameworks, you can have learning and advocacy, but stakeholder interests can compromise the entire process. Then you need collaborative support for HTA, especially in countries that do not have not yet institutionalized HTA. So these 5 factors are really key when it comes to institutionalizing health technology assessment. So in conclusion, what are the policy and research implications of this work? So this work shows that institutionalizing HTA requires a systemic approach. And this systemic approach must recognize that, must ensure availability of organizational resources, availability of legislation and policies, availability of learning and advocacy, as well as collaborative support, especially for countries that are just starting out. Then it also identifies that it also must recognize stakeholder interests. Yeah. Then for research implications, the conceptual framework identified in this review can actually support countries to develop an implementation roadmap for HTA. So using that conceptual framework, you can actually look at, for example, organization resources. Where are we at in terms of funding HTA? Where are we at in terms of skills for HTA? Where are we at when it comes to capacity building, things such as those. And then we work towards strengthening those to support institutionalization. Then the second point here is it provides a systematic approach for researchers seeking to identify factors that influence. Again, this will provide a whole system perspective on the factors that will either support or undermine institutionalization in a particular context. Thank you very much. I am happy to take questions. Oh. Nothing was understood or everything was clear. No questions, no comments? Okay. I can invite Brian to go ahead, and then if there are any questions afterwards, you can ask me.
As Brian comes, I think it's time for us to stand up for a minute. They say sometimes after lunch, the upper one gets heavier than the down one, and then the head bends. So let's just, for a minute, and just stretch. Most of us arrived maybe today or late last night, so it's understandable we didn't sleep very well. So let's stretch, Okay, thanks. Can sit down.
All right, thank you so much. Yeah, so I want to just talk about HTA in action and then build a case in Ghana. And actually, we'll be doing 3 cases. So, yeah. So we will be talking about application in the decision-making context. And then the production process, we'll talk about 3 cases of applications, and then we'll talk about how we make or translate decisions, or how we make decisions without ISA thresholds, because we've not established an ISA threshold, and I know we've had a lot of discussions on ISAs today. So we have a way of maneuvering in practical settings, and I'll be talking about that as well. If there's more time, we can look at the other 2 on the other side. So HTA application and decision-making context. I think in all of this discussion, a country would have to take a decision as to how they want to use HTA. Okay, so the way before we set up, we try to look at other places and how they have set up. And you can see that clearly there's an emphasis on certain specific aspects of the health system where HTA would apply immediately. So then we took a decision that, considering our context, how we prioritize policy options is critical. Or discussions around our benefits package is important. Essential health services, selection of health technologies, pricing strategies, as well as its links with procurement, all those things are important. And one criteria that actually underpins these areas of application is the fact that there are clearly identifiable decision structures around these areas. Because at the end of the day, if you want to apply something, where would it be applied and who takes the decisions and who needs that information is important. So that was important in picking these areas. Now you can see that for each of these areas, you have clear decisions. So Ministry of Health Policy Planning, Monitoring and Evaluation are responsible for decisions around policy prioritization, as well as other agencies. When it comes to selection of health technologies, there's a ministerial committee around selection of health technologies. They need the kind of analytics that we do for HTA. When we talk about benefits package, the health insurance, forgive me for the abbreviations, the health insurance, the ministry plus other stakeholders, they make decisions around benefits package. When it comes to essential health services, these are also Ghana Health Service, a service provider, private sector entities, Ministry of, and again, the health insurance. When it comes to pricing related matters, it had to do with the ministerial committee on prices and the procurement entities that be. So then this establishes your demand, and this establishes how you formulate your analysis, because now you know a clear audience and you know the areas that are relevant. And I think this is important in the application process. So in producing these analyses for people to use them, then you also need certain things in place. But I must confess that we didn't start by establishing the process. We built the process as we went along, and then we established standards for it as we went along. So this is informed by looking at best practices and also from hands-on working, what we learned from the process of producing. So the three cases that I am going to talk about, some of them conform to this because some of them were done when this process was taught in establishment. And some of them also are now following the process because now we've learned a lot and we've documented. So the initial is topic nomination, and we established some time frames around that. Then a topic selection process. The topics are approved. There's a technical working group that will do analysis, the assessments. But here we can actually co-opt out of the technical working group to have the analysis done, and then the TWG can appraise. We can have deliberations of the findings, and then there's a communication component, and we don't leave it. We try and do some follow-through work around implementation. So it could be rapid or it could be a full ATA depending on the time frame that we have. And then this is where our methods sit. So if you have methods guideline, it informs the assessment directly. But in terms of communication, whatever outcomes that come, we also have a system for appeals. I mean, if somebody is not happy with the outcomes, they could appeal the decisions. And then in implementation, we have some implementation research to help optimize, because at the end of the day, we know that decisions or evidence does not necessarily translate to real benefits in the population, because interventions that are proven to be effective in implementation could be discounted very, very. So let me give a typical example. So a treatment effect is about 80% effective. But because of non-adherence and because of people variations in response and all that, you may actually deliver about 60% to the population. So this helps us to translate what all the evidence is saying in real things, in real terms to the population. And that's very important in our context. Maybe in the question time, we can discuss more on this one. Sorry. So there was a discussion earlier about criteria. And I think, so this is, I think someone shared something on the Thailand case and the criteria that Thailand uses to identify topics that are relevant. So now Ghana is looking at potential for cost effectiveness, the numbers, the benefits, the equity aspects, as well as the budget impact. And here budget impact is not an analysis because at this point, you've not really done a comprehensive solid budget impact. So we are talking about impact in terms of household economic impact, which you can simulate easily with just limited information, and it's not too complex to gauge the potential impact on pockets, basically. Then also, when it comes to standards, we are looking at a reference case, and a reference case basically methodological standards that will address what is important and the boundaries of your analysis, which you have to look at. So it guides just the conduct and then the reporting. So what you do in the analysis is guided by some standards. Because in this analysis, a cost from the perspective of a payer versus the cost from the perspective of the government could change the scenario of the analysis. So if I see that this is not looking very well, when I look at it from the side of the patient, I will choose to do it at the side of the government, just to make the analysis look good, you see. But the key thing is to bring transparency and standards in how these things are done and how they are also reported. So that is guided by reference cases. And it helps you to plan the production, helps you to harmonize the expectations of the decision makers. So for instance, all those decision makers I said in the previous slide, because of a reference case, now they know that if I'm being given an HTA report, I'm expecting to see certain things. and certain things reported in the analysis. So the producer and the receiver are all expecting certain minimum standards in the conduct and reporting. And these are all important in terms of having a transparent process and then working. I know this is dense, but if you ask questions, we can go into this in terms of what is important in the context of Ghana, what we are considering for our reference case. I will skip this, but all I'm saying is that this is a set of standards in the conduct of an HTA that guides everybody. We are talking about things like we prefer a cost utility analysis. And if you don't do a cost utility analysis, let us understand why you didn't do that approach. We expect that your perspective to the cost is a societal. And I think the previous presenter has mentioned what a societal perspective is to cost. And if you don't do a societal perspective, then you can justify, or you have to include in your report a justification of why that was not done. Okay, and so on and so forth. We have recommended a discount rate that you would use because costs that are borne today versus costs that are deferred in the future are not the same. Okay, so if I said that I have the $100 here, and I said, would you take it today or take $110 next year? I could get some varied responses, is that not so? Who would want $110 in a year's time? You would rather take $100 today. But though $110 tomorrow is actually a larger sum, right? But everybody wants benefit today. But if I said, I'm levying everybody and you all have to pay me $100 today, would you pay it to me today or you want to pay it tomorrow? You see, so there's different directions for preferences that we defer costs for the future, but we want the benefits now. So the idea of discounting is to bring into the analysis the fact that benefits are valued more in the present than in the future. You see, so those dynamics are also important. And then we discount at 3%, but we do a sensitivity analysis as in scenario analysis that if the analysis is discount is 0% or up to 10%, how does the analysis look like? It's basically a scenario-based analysis for all that. I'll leave the rest for discussion if we have time. So now let's come to the application instances for HTA specifically. In all of these analyses, there are broad domains that you have to include in the analysis to make it an HTA. So these dimensions include safety. You have to analyze the safety. You have to analyze the efficacy or effectiveness. You have to analyze for social and ethical context. You have to analyze for organizational and then the economic context. So all these are dimensions, but broadly, you can say that we are looking at effectiveness, economic evaluation, and then ethical, social, legal, organizational, or some will say institutional. Now, when you put it all together, we have 3 cases, and I'll use the 3 cases to illustrate some things. So the first one has to do with hypertension, which we worked together with IDSI on. And this piece of work was the very first test case for HTA. And if you look at it, so this is the cost effectiveness plane that we saw in the previous slide, but we're just focusing on the upper right quadrant. So you have costs here, you have DALIs avoided here. And these were calcium channel blockers, a type of drug that is used to treat hypertension. And these are diuretics. But just like what the previous presenter said, if you have interventions that are closer to this axis, it tells you that you are getting more benefits at a lower cost. You see, so that is good. And then if you have interventions that are way up here, that means you are paying more for a smaller benefit, meaning that your axis has to be benefits. If your axis is harm, then it's a slightly different scenario, how you interpret it, okay? So that is important. This is our case for hypertension. The report is online. You can actually look at it in more detail. But because of this, our treatment guideline for hypertension that year, we updated that guideline to prioritize that if a patient comes and is having hypertension that is not complicated and is newly diagnosed, then your best first line approach, you should prioritize calcium channel blockers and diuretics. Before that, it was just a bundle of antihypertensive that had been defined, and the physician could pick from any of them. So this helped us to prioritize these two categories over the others. So we said that if you are not complicated, use these two categories. But then if the patient has any complication, then if there's a heart issue involved, then go this way. If there's a renal kidney issue involved, then do this. If there is eye involved, do this, and so on and so forth. So it helped us to clean up the hypertension treatment in Ghana, this particular analysis. Then also we went ahead to do, there was an example of how you can use it in price negotiations. So we did this in Ghana, and some of the drugs in the hypertension work, the model was amlodipine, the 5 milligram and the 10 milligram. But in the model, when you varied the price for 5 milligram, either dividing it by 2 or multiplying it by 2, this is for calcium channel blockers, like I said in the previous slide. But you see, it stays it just moves, dividing the price of the 5 milligram by 2. Look at this one. You see, it just moves just below the line. This is just above the line. That is just below the line. So it doesn't change the cost effectiveness too much. But then if you multiplied or varied this 10 milligram tablet by 2, you see, it's a very significant change in terms of the cost effectiveness. Now, because of this, the pricing committee, because I said in all of this, when there's a decision-making entity that receives the analysis, it helps you to apply. So this was given to the pricing committee, and before they went into negotiation, they knew a certain price which would be too much to pay because of what they saw in this kind of analysis. So they go to the negotiation table, they have an idea of the range of kind of prices they should be landing on. And in those negotiations, if private sector says that, well, you are expecting us to sell at this price, but it is just not possible. The maneuvers around that had been the fact that in that case, then we negotiate for larger volumes for you. So there's a procurement process that pulls volumes together. And the moment they see volumes, then you can have a good discussion about lower prices. Okay. There are other complications around it in real terms, but this is the idea. So because of that, we called something framework contracting in Ghana, and this informed the pricing of hypertensive amlodipine, specifically the 10 milligram. They said, why are you not interested in the 5 milligram? We said, just do the 10 milligram for us. Because we know where we are coming from. The next case is childhood cancers. And this type of cancers can be very aggressive. This is a child, and you can see that there's a lot of improvement with treatment. And if you don't step in early, that can lead to a whole lot of things. So there's a political discussion around this, but then together with Norwegian Institute of Public Health, we produced this HTA that informed our decisions around childhood cancers. Now you can see that when we did like the calculation that we did this morning, calculating the ISA, so we also calculated the ISA just like you calculated this morning. And then we had this minus $219 per benefit. And the benefit here is DALYs averted, disability adjusted life years. Now, when we did this, you see that this is a negative ISA. And I'll come and talk about the nuances of this little negative that is here when it comes to decision making. So somebody asked, do we address uncertainty into the discussion, into the analysis? Uncertainty was done here, and whilst, you know, the ISA is like we put it as a dot on the graph. But this one, uncertainty, to play out several scenarios. And you can see that all the dots are in this quadrant. This quadrant, as we heard this morning, is less costs, or in other words, savings, and then more benefits. So what do you think? Because from the presenter, I heard very well that they were saying that things in that quadrant they are no-brainers, right? Something that is saving you money and giving you benefits. So this is one of the reasons why Ghana decided to go along with reimbursement of childhood cancers because of this information. And then we also did a budget impact. So somebody was talking about the fact that you just look at the cost effectiveness and move on with it. No. So budget impact, year 1 cost, year 2 cost, year 3 cost, up to 5 years. And this is the total. Okay, so up to 5 years, this was really the cost. When you sum it up, a little lower, just a little lower than $1 million. And the insurance picked this and sent it into their actuarial model. And this is very important. So the budget, in fact, is telling us that you are saying that this is cost saving at this point, that when we invest in this, we actually, it's beneficial to us. Fair enough. It's efficient to invest in us. How much would it cost us in 5 years? That was the figure. But then the insurance picks this figure and they put it in their actuarial model to say that, well, Beckett Informa is not the only thing that we are working with. We are reimbursing for a ton of other conditions. When we absorb this budget impact, are we sustainable? Are we still able to run the insurance? And the answer was yes. So you see, it's not a single dimension to make a decision, but then you consider other things as well. And that is exactly the case. The third instance, the last instance, is with pneumonia management in children. And it was pretty simple because amoxicillin is supported through evidence from WHO and a lot of secondary data that is effective in pneumonia management. Now, the use of suspension amoxicillin versus dispersible tablets, all of these three, was up for discussion. So when we ran the analysis, and here, first of all, safety and efficacy, we found data that established that the formulation really does not, it's still amoxicillin in there, just that one is a dispersible, one is a suspension. Does it contribute to outcomes instead of clinical outcomes? The answer was no in the evidence synthesized. However, the dispersible tablets had better adherence compared to the suspension. So in other words, if you look at the effect, they are the same, but in terms of clinical outcomes, but then for adherence, this one is slightly better, okay. But we still went ahead to assume that they are the same in terms of clinical outcome. And then we analyzed, so what is the cost? So this became a cost minimization analysis. Which of the options is giving us a lower cost? The reason is that we didn't have so much funds to spend on this. And this is very important because we've been discussing things around the HTA process itself becoming cost effective. There was absolutely no point to even analyze for the effectiveness comparatively because clearly one is looking like it has other benefits to the other. And this is telling you that it could come at a lower cost. It could come at a lower cost. So we looked at only the costs for the dispersible tablet, 3 of them, and realized that this particular presentation of the dispersible tablet actually saves you all of that compared to this one. And this is where I want to make a point here that navigating this course without ICES, one of the key things is your comparator. If you select, because the ITHA gives you an absolute comparator, which is a threshold that you are comparing with. But in the absence of it, it means that you have to carefully select the comparator in the analysis so that a simple, well, this pathway is giving me this type of ISA and that pathway is giving me this type of ISA. How does the two look like? And what is the margin of that difference between the two? And here we thought that having this a little over 800,000 in terms of savings to the insurance was worth it. And when we presented it, they agreed. So if you look at this, is a live thing from the health insurance website, you can actually pick it right now. And on that website, you can see that there's amoxicillin dispersible 250 milligram listed. We actually also recommended a price range at which they could introduce the product because we did a price, we picked the international prices because at that time, the product was not in country that we could get a good price on. So we picked international prices and then computed it's considering import taxes and all of that to arrive at a typical country price together with exchange rate fluctuations and all that. And then we actually gave them an indicative range of prices. And that's exactly what they did. They told private sector, they said they could supply at that point. So you have it listed. Now, again, if you look at here, they're also talking about the childhood things. So on this health insurance line alone, this is their corporate website. You could see a story being told here about what HTA can do in terms of a lower middle income context. Now, my last session has to do with the nuances of operating without the threshold. So we've seen this already, but maybe the only thing I will say is that this ISA calculation, you need to open your the alert that your reference is what is at the other side. And then your new intervention values is what is in front. If you reverse the order, you'll be calculating something different. So that's very important. You're calculating something different. And it is not benefits per cost. It is costs per benefit. So one is up, one is down. And you need to be careful what you include in the costs and then what you include in the outcome. Because for costs, it is the impact of the intervention on resources. But for outcome, it's the result of the use of the resource. And sometimes people confuse the two. So they move costs, things that should be in the cost, they put it here. And because all of these things, you can put financial value to them. You see, so if you don't place things well, you'll also be calculating something very different. All right. So having said that, when you look at the axis, and the axis is cost and effect, as in the value, just the cost, you will be dealing with, so in this instance, your ISA is actually the gradient, like the difference here, and then the difference there. So it's the gradient. If you put the axis as the change in cost, not the cost, but the change in cost, then you'll be dealing with the true cost effectiveness discussions that we are having. This is about change in cost and not just cost. So here, in this instance, your ISA is now the difference between that point that you have there and then the origin. Okay, but in the other instance, it will be, you will need 2 points, an intervention and another intervention. So you look at the difference. But here, the difference is in the axis. So you can just look at the point versus the origin, and then you can get your ISA. And that's very, very important, because in that first instance, you will be dealing with what is typically called in health economics a frontier. And it will be talking about things that are on the outer border being efficient or cost effective, and then those here not. So we just need to look at the two and know what we are dealing with. And so when you present these analyses to decision makers who know what you are presenting to them, these are the sort of things that they engage you on. That because the incremental cost is telling them that upon all the costs that I've put in, these are the additional costs that I have to put in. But it's a different story in the other, because those are absolute estimations. Now, I think we've discussed this already. If the issue is about pay more, get less, in simple terms, the new intervention is dominated by the old one. We don't want that one. And then if it is about this one, we said we are happy with it. And then if it is over there, we are not too sure. But if it's over here, we do a lot of cost effect analysis in that quadrant. When it is here, the issue raises in the decision-making space, it raises a lot of ethical issues, because what you are telling us is that we will accept something that is not as good as an alternative so that we pay less. You see, so questions are coming in terms of, is it because we cannot afford? Are you sacrificing benefits for money and all of that? So discussions here can be easily political and very difficult to take and navigate this course. I'll talk a little bit about this. These are drugs that we use to I made these up. These are not real drugs, okay, simulated. But I want to illustrate a point here. You see, let's say this drug, the change in cost is this, the change in cost is that change in cost, this one to change in effect is all of that. You calculated an ISA today, right? So if this is like that, then it's saving you 2,000 and giving you benefit of 1. If you divide that, you have an ISA of that. If you compare this one, this is saving you more money and actually giving you more benefits. Is that not so? This is saving you more money because it's, and this is actually giving you more in terms of the effect. But look at the ISA, the same ISA. Why is it like that? It's like that because the ISA is actually a relationship between cost and effect. So whilst you put it as a point, it's actually a line. And any ratio that fits the criteria, it's like saying that 4/2 is the same as 2/1. That is by it being a ratio, this is what an ISA tells you. And that's the effect that you are seeing here. You see? so that if you're looking at a decision-making context on an ISA, you need to consider a lot of context around the ISA. So in our space, we don't deal with point estimate ISAs without context because it could be misleading in translating it to evidence. People would ask you about the sensitivity analysis, as I mentioned in the reference case. How does the differential cost look like? How does the differential effect benefit also look like? So they can place the ISA very well. Okay. The same applies to this other set. If you do this other set, you realize that you'll be getting the same story, but you have to place it very well. So here, you place things here because this thing is negative and this is a positive. So that will be coming here. Especially problematic when your ISAs are negative ISAs. So that minus 219 that we saw in the Beckett lymphoma, it could also be here. You see, that's this case. If you have that, the negative, just that point estimate alone could also be here. And what does this place say? It tells you reject, right? So it could be misleading if it's just the point estimate, but you have to look at the ISA in totality, and then you can actually be guided to make a good decision. So in the absence of a threshold for hypertension, what we did was that we had two setups. The calcium channel blockers were lower and the other drugs were up there. So comparing, we just compared this with that, and then we made a decision and prioritized the ones that are closer here than the other. When it came to Beckett lymphoma, the ISA was here in this quadrant. So this one was pretty easy because we got the context. So far as it was negative, we had to know where exactly it was. And when we knew exactly where it was easier to make that decision. However, for the anemia thing, it's actually on the line because the change in effect we are saying is 0. Because suspension and dispersible tablet, we are saying that they all have the same effect, but for adherence. Okay. And if they have the same effect, we are looking at the one that costs less. So that is actually your point. And that is also a very easy decision to make. Okay. So maybe I'll just end it here and say that because of some of these technicalities around the ISA, people also rearrange it. And this is the formula that we just change in cost, change in effect, right? People rearrange it and they put this one here. Just move this one on this side and then move this one here. And then you calculate this one. This is net benefit, incremental net benefit. It's linear. If you look at the structure of it, it's linear. So it's a lot easier to manipulate this. Okay. But when you have it in a situation where you realize that it will be difficult, you can actually rearrange the arrangement like this. And then you are a lot easier. There was a question earlier about how we consider all of these dimensions together. So in Ghana, we said that, is it safe? Then you do not even think about it. But if it is safe, then you can consider whether it is effective. So if it is safe, the principle is first do no harm. You may invest in it if it will not kill me. But if it will kill me or destroy, then forget about it. Okay, so that is it. The safety is the first thing. And then is it effective? If it is not, forget about it. And if it is comparable, as in the same effect in terms of it being effective, like the amoxicillin case. So if it is effective or comparably effective, then look at it. Which one is having cheaper, which is the cheaper alternative? All right. Or if it is cost effective, like the hypertension, then we look at which one is good value for money. These two instances will be eligible, but this one, when it is as effective as the existing, but it's not cheaper, it is not a good deal. But when it is cheaper, then we can consider. So your dimensions for safety and effectiveness and cost effectiveness is handled this way. But then the other dimensions about feasibility, including budget impact and all of those things would come here. Would come here. And this is deliberation. So we have a steering committee that will sit down and look at all those other dimensions as well. Just like the CEO of the health insurance picked the analysis and looked at it in terms of feasibility and affordability, considering their own actuarial model as well. So that happened in this box. All right. Then a decision is actually made. So that's how we put all the things together in our context. I think it's okay. We can pause here because I think the time is up, and then we can take questions.
Yeah, thank you very much. Brian, thank you very much for that wonderful presentation. And for the work you did on institutionalization also. In this kind of gathering where we are doing capacity development, it's important, especially against the background that health technology assessment is quite new. It's important that we begin to de-emphasize the fact that health technology assessment is about cost effectiveness analysis or economic evaluation. No. It's just a part of health technology assessment. Because once you begin to dwell on economic evaluation, a lot of people will run away. And that's why at the end of the presentation, nobody wants to ask questions because it's still very stochastic, you know, like the director there, you know, is a stochastic man. So we need to make that very clear so that people know the area they want to go to. That's why I like the way you wrapped it up, okay, to show that there are areas like the deliberation aspect and all that. But there's one area that we tend to forget, which is very, very important, and without it, HTA will not work. Is the area of policy engagement, stakeholder analysis, the role of policymakers in HTA. It should be central in health technology assessment, okay? Yeah, so because everything you do, you must draw it from those stakeholders. So that's the point I want to make. Then the second thing is, what is the take-home message when you presented the health technology assessment kind of toolkit, you know? So what is it there for those who want to do it? What is the practicality? So is it clear? Is the toolkit clear to them? Do they need to go to a special school to get that? Okay. Because I have had opportunity of looking at that toolkit, and at times it appears a little bit complex. So if it is possible, you can, you know, make it simpler, you know, because, you know, what we want to achieve, I believe, is that people can go home with something and begin to replicate it somewhere. That's, for me, that should be the goal. Then the same thing goes to institutionalization. My question in institutionalization of HTA is, in Kenya and in Ghana, where it seems to have been institutionalized, who was or who is the driving force? Because that's very, very important. If you know all the details and there's nobody to drive it, who is driving it? Is it the researcher that is driving it? Or is it the policymaker that is driving it? My take is that if you arrange the institutionalization around policymakers, then it will work faster than when you arrange it around researchers. Okay. Yeah. So I want to get your insight in this. You know, so how can, for example, in Nigeria, okay, of course there are a lot of them here and they're interested in this institutionalization. So who drives it? How do we get to doing that in Nigeria? You know, because they say, don't forget, they say we are the giant of Africa. But small countries like Kenya and Ghana are now doing it, you know. So how can the giant institutionalize HTA? That's on a lighter note.
It is very good that you have said that it is on a lighter note. Because I'm sure there was just about to be an uproar of rebuttals.
Again, on a lighter mood, when you're doing the presentation on the quadrants, when you talked about Southeast and your arrows, I like to use, when I see something good, I like to use green instead of yellow or red, because that's a green, yellow, red concept of driving.
Yeah,
is already in our mind.
Yeah.
Thank you very much.
Thank you so much. Thank you so much. Since he has a cluster, maybe I'll just try and respond to that. Then we can have others also coming in. So in terms of stakeholders, I think stakeholders are critical in our process around the scoping of the work. That is where we actually do a lot of active stakeholder engagement. However, even here, there is engagement of stakeholders here because you engage stakeholders in the topic nomination process so that people don't sit in their offices to just say that this is what we should be doing. What, for instance, the issue around childhood cancers, we also had discussions with one of our teaching hospitals where cancer is treated. I personally visited that particular treatment center, the Kolebu Teaching Hospital, and there are oncologists there who are astute oncologists who will tell you exactly what benefits and exactly what the problem really is. So, for instance, one of the professors there who is part of the Treat Children Every Time actually painted the social cost that is related to that childhood cancer thing. What is not spoken in the numbers, you hear it from the stakeholders. You see, so for instance, the fact that, and it's part of an assessment that we're doing before. So talking to mothers and people who come to the child care, you hear stories like, somebody's sibling, like if you have a family of 3 children, 2 children will opt to stop schooling. So family resources can be channeled to save their other sibling. These stories are not in the numbers. They are the things that you hear when you do deep stakeholder consultation. So for me personally, that particular childhood cancer thing is because I saw the faces of those children, some with very severe retinoblastoma that is popping out and oblivious of the danger. They are playing with toys. You see, so these things have an effect on you. And for me, if I do things like this and I even retire, I think I would have made some impact. So these are some of the drivers, but there are soft issues around some of these things that if you don't do deep stakeholder consultation, you would miss it in the analysis. And it brings relevance to the work that you do as well. So we do stakeholder consultation here to help us scope the thing that we are trying to do, the analysis, and also at the top to help us navigate what is important. Now, I think you had another question on where or who should lead it. For it being a health system decision-making thing, I think that for us, we took a decision that it should be placed in the Ministry of Health to help to move the agenda forward and all that. It may be different for other contexts, okay? But one key thing I think I will highlight is the fact that I think identifying how the system is placed and looking at which opportunities exist to make an easy entry for HTA is maybe the key, in the sense that before all of this started, Ghana has at least a structure for development of treatment guidelines, and it's something that uses evidence. You see, so that was a low-lying fruit. In terms of people that will use it, the health insurance and the CEO at the time had been engaged on these ones, including the chair of these committees that select medicines and all that. You see, so we decided, okay, fine, we're not going to start something very different, but these structures already exist. Let's implement HTA using existing things. All right. So that helps us to lift, because we are not telling you that stop doing this one and then go and do another thing. We are telling you that modify what is already existing so that we can put on this other tool that helps us. And I think it was a lot easier to articulate these discussions this way. And that is how HTA is structured the way it is in Ghana, a secretariat at the Ministry of Health, a very open, multidisciplinary technical working group that is able to co-opt expertise as and when it needs it. And then a steering committee, which is more of a decision and governance entity made up of top management of the decision makers or entities that implement HTA, okay, on that committee. Because of that, though we don't have a legal framework, and our legal analysis have actually unearthed this, we don't have a legal framework that binds people to implement, but that advocacy and that environment on that steering committee becomes a catalyst, because you are CEO of the regulation entity, I'm CEO of the insurance entity, he's head of the service provision, and he's a minister, and he is that. Why aren't you applying the evidence amongst, so there's a peer effect at that point. We've all seen the evidence. Why don't you want to apply it? There's no law, but there's that. So it thrives on this kind of strong advocacy, but there's a downside. If people move on, people retire, it means you have to re-engage and then make sure that the new people who are coming are also on board. So for instance, our CEO for health insurance has changed, and we need to also, and the new person, we need to work so hard. So it has trade-offs, but in the absence of a threshold, we are managing this process. In the absence of a law, we are also managing it this way. All right. So you would choose where to really put it and who to lead it, depending on context. Yes. There was a third question on. Okay. Color coding, I agree with you. This time you see red for. Then the last one is the key messages in all of this. I think our systems want to achieve universal health coverage. And I've learned through all of this that UHC actually makes a case for health technology assessments. So that if you introduce all of these complex discussions about economic cost effectiveness analysis and utility assessments, and amongst health economists and evidence-based scientists, these are things that we can easily talk about. But somebody is a decision maker in an organization. His fundamental training has nothing to do with the area where he's providing leadership. So articulating these ideas can sometimes be difficult. But if you are talking about universal health coverage, that can be broken down because that conversation has been ongoing for a long time. And you are talking about a tool that can help us deliver UHC through optimizing our use of resources so that we can have cover more services with small money. That is a conversation that can easily be articulated. So I think UHC is a strong case to have this in terms of a key message from all of this. So all these tools and the processes and the reference cases and all of that can be wrapped around a UHC discussion. And I think that is a priority for a lot of countries. It's a political lever as well. And you can actually set agenda through all of this as a key message in an agenda process. Yeah.
Just want to ask, like, for the example you took on hypertension, now the physicians or the medical people, they have their different guidelines. What is the first line treatment, second line treatment, and regarding this, let's say calcium channel blockers, AC inhibitors, what to choose? Like, I mean, they have their clinical guidelines and they have their pre-notions. So how did you factor that in to, like, let's say they insist on going for AC inhibitors as the first line, and whereas it's may cheaper to start calcium, something else. So how did you factor that in their technical power or the influence in shaping the policy and questions?
Yeah, I think this is a very good question. So this part of it is implementation. So after everything, you need to reduce the message into things that people can appreciate. And that's exactly what happened with hypertension. So after hypertension, there was actually a nationwide training on the change of guideline. So this implementation includes change management, because before that, people had been managing per what was before, and they've gotten used to that. Okay, so now if you're prioritizing calcium channel blockers over diuretics over the other types, calcium channel blockers and diuretics over the other type, they had to go with a lot of training. And there, clinicians will ask you a lot of questions. Why should we do it like this? And you need to show your evidence. So that is what happens, that all of this has a lot of downstream things that should be addressed. For hypertension, like you were discussing, it was training and engagement of prescribers. And that had to be done nationwide, together with disseminating the new guidelines. And that is how we're able to send the message across. That was one. For Beckett lymphoma, we have actually designed, after the insurance picking on the recommendations, we've designed a 5-year implementation project to address the downstream things, because the issues identified in the analysis includes even the fact that people moving from the very remote areas to treatment centers, which has, because it's cancer, is sitting at the very top of the health system, and it will be located in urban areas. And sometimes they cover a lot of mileage. And when they come, they're not able to get a place to sleep, because the care can take them about 2 or 3 days. So that also adds to their cost. You see, so that downstream project seeks to address some of the social costs associated with it. So what I'm saying is that all of these do not end in an ISA. The story doesn't end there. It doesn't even end at the decision point. Okay, but the downstream issues are a lot, and it depends on what you are dealing with. A change of guideline, then a change of guideline must go through its natural change process. Is it a new treatment that we are now reimbursing? You have to do awareness creation. People should know that now insurance covers this to generate the demand, so you catch the cases early. There needs to be updates of the specialist guideline, so they know that, yes, we are covering Beckett lymphoma or childhood cancers, and this is the guideline that we are offering. There needs to be awareness that, so all these things come through to actually send those recommendations or deliver the recommendation to the population. I don't know if your answer is the question, yeah, but in your specific case, it has to do with training of physicians in this aspect.
My question is actually pretty short. So in Ghana, who actually does the assessment and who does the appraisal? Because, for example, in Egypt, we mandate that the manufacturer submits the value dossier according to the standard template that we have developed, and then the UHI and the UPA, we jointly appraise the evidence. So how does it go in Ghana?
Okay, so this is a very good question. Okay, let's add more. Very good question.
Thank you so much for the presentation. And actually, the last comment that you made was quite helpful, that HTA is not the end in its own, but the end of a new beginning, because a lot that needs to go in to ensure that the results are utilized. I think that's quite eye-opening, so that we don't take that once you finish HTA, that's the end. But just quick one, and the first question would be to last presenter before you. In the literature review done to determine factors that affecting institutionalization, were you able to see any relationship between the health system organization, I mean, the country's governance structure, and the easiness to which HTA process are institutionalized, be it decentralized or centralized governance structure, because each of them comes with a lot of, with their own challenges. And then for Ghana, I mean, I would be curious really to know where is the starting point in terms of capacity, and what are you doing to ensure that these capacities are sustained? I mean, you just started talking about retiring, so who will take the baton after you?
Okay, you want to start?
I appreciate the question on the literature review, whether we identified health system governance structure as influencing the ease of institutionalization. And I have to say that it was not evident in the literature. Maybe it's something that should be explored. But one thing I know from reading literature is that even in decentralized settings, having a national coordinating unit helps despite the decentralization, so that the process is able to be standardized across the different devolved structures. Yes, so yes, so we did a study. Thank you. Okay, thank you for that. So based on the literature review, I have to say that, but what he's saying is we did a study in Kenya to examine factors that influence institutionalization of HTA, and we adapted the framework. Kenya is yet to institutionalize HTA. It's not routinely done to inform policy and priority setting decisions. And one of the factors that we found, Kenya has a devolved, for those who are not aware, Kenya is a lower middle income country in sub-Saharan Africa. It's based in East Africa, and it has a devolved system of governance. So we have one national government and 47 county governments, and health functions are devolved to these county governments. So the national level is responsible for policy formulation, and it also oversees service delivery in referral hospitals, level 6, what we call level 6 facilities. And then we have the county governments, which oversee service delivery in the counties, the 47 counties. So they are actually responsible for a lot of the health service delivery, and they have their own budgets, and they're able to, prioritize how they'll allocate that. So what we found that in as much as there's the conversation around health technology assessment, there was limited awareness at the subnational level. And this was potentially a barrier because they're not aware of the value of HTA. And so they're not likely to employ it to inform their decisions. So as I mentioned in my literature review, stakeholder interest and stakeholder understanding and awareness is very important. With policymakers' awareness and understanding, it drives the demand for HTA. And once they demand for HTA, then they're likely to use the HTA outputs. So without that, then it might compromise the institutionalization process. But yes, future studies for the researchers in the room, you can potentially explore governance, the influence of governance structures on institutionalization of HTA.
All right, so thank you for the response. I think so. What is left on my list here is the capacity issue. Oh, okay.
Just before you respond, thanks, Brian. I'm Beatrice Zamboko from Kemri in Nairobi, Kenya. So my question, thank you for that presentation. At least it puts the HTA into perspective. But just following up on his question, as a clinician, you always follow clinical practice guidelines. So you say you talked about implementation, but also the country level clinical practice guidelines are defined by the global level, mostly from the WHO. So at which point do you consider those guidelines as well? Thank you.
Yeah, so in terms of the global evidence and where it comes in all of this. So at the point of the assessment, you can look at a lot of data. And if it is something that is clinical, because the questions that we answer are not only clinical issues, it's policy issues, intervention packages, and all of that. But if it is with a clinical issue and there are reputed guidelines, including WHO guideline, it is considered at this point in the assessment. Okay, yeah. So those are not excluded. You have to look at all of that. Let me give an example. Before HTA was officialized in Ghana, where we had structures, some years back, it was, and that's what I mean by using existing processes to institutionalize. So before we institutionalize, there was already a process on evidence that informs clinical guidelines. And WHO introduced artesunate injection for severe malaria, I think around 2010 thereabout. So it was artesunate and then artemether, if my memory serves me right. Now, so Ghana also looked at the evidence for that committee. And after looking at the evidence, instead of just saying that, yeah, we're adapting because WHO says it's good, the country said, no, we would defer the decision until we're able to establish a reliable supply for the product, you see. So this even guides you in your uptake of recommendations. It was not a no, but it was a defer. And the country worked seriously to establish supply, and then the product was taken up. You see, so direct answer, it is covered here in the assessment. But then the broader issue is that this process actually helps you to consider that from reputable guidelines, including WHO guidelines, plus other country context issues, so that you have a more holistic decision in your context. All right. Now, when it comes to the issues around analysis and appraisal, so here, the HTA structure, okay, is actually what you see in the blue and the red. So blue means that it's an action that the technical working group does. So technical working group is involved actively in topic selection, of course, working with others, but the TWG leads on this. Steering committee approves the topic, and then the TWG does the stakeholder engagement work, and then also does the technical the assessment. So you can see there's an analysis subgroup here, and here there's an appraisal subgroup. All right. So what happens is that if you are in the analysis subgroup, you cannot be in the appraisal subgroup at the same time, else you'll be appraising your own work. Okay, so we have subgroups within the technical working group for various things. So even the appeals, there's a subgroup for appeals. All right. And the reason is this, everybody doing something related to this must understand the process end to end. And to optimize our capacity building initiatives, we always try to target the entire TWG. Though sometimes people are busy, they're unable to come and all that. Those are the practical things. But we try to target everybody so that if I'm in appeals, I actually understand what they do in appraisal, and I understand what they do in assessment, and I understand what the reference case says, and I understand what we are doing. So it's easy to talk on that committee, and we understand each other. But there are subgroups for all of these functions, all within the TWG, but they have different things that they are doing in each group. That's how the Ghana process is established. I think what has also helped us is the fact that because it's new, and I'm coming to capacity building, because it's new and we are learning as we go, you should have seen our very first hypertension. So you realize that as you go on, your processes improve, and then you get better at what you do. For the dispersible tablets work, the pneumonia in children work that I just said, at a point, we realized that the way we wrote that report at that time could actually be improved. So we went in and looked at the analysis again. Of course, the outcomes didn't change, but then now we were able to explicitly talk about the perspective to cost, for instance, because now we have a reference case, you see, and we're able to specifically argue out in that report why we didn't have to do the comparison of effects, okay? Because then the argument is that if it is the same and this one is costing you less, then if you introduce the added benefits, it's actually going to extend your decision rather on it being the best option over the other. You see, so you improve as you go and you build capacity as you go. I don't think it will be a good model. This is my personal opinion. I don't think it's a good model to say that I will build capacity and then I would do ATAs. I think that this is it's not a linear process. It's rather an iterative process where you have to get something moving and then you will improve it as you go. And the capacity building has to also be practical. Yeah. I think thanks to, I have partners in the house, and I'm seeing Lika from Norwegian Institute of Public Health is a critical partner in the Ghana work. I've seen University of Ghana School of Public Health. They are sitting together by each other because they are friends. I mean, so through Lika, we've had a lot of collaboration with Norwegian Institute of Public Health to do a lot of work in Ghana, not just Beckett lymphoma and childhood cancer. We are moving that partnership to do other things. And then through the University of Ghana, we've had some of them also joining the technical working group, and they contribute a lot to the work. So these two human beings sitting here, the story they are telling us in this presentation is the power of international partnerships and networking. And that's what Leka is saying. And then Richmond sitting here is also the power of in-country partnerships. And I don't think that we could have established all of this without partnerships. That is I cannot overemphasize that. So the capacity building, we also have it in the networks that we have developed. Okay.
Any final questions? Sorry. Oh.
Well, first, thank you, Brian, for your great presentation and for your very nice words. So my name is Lika. I'm from the Norwegian Institute of Public Health. And actually what you said, there's two coins to it, right? Like on the one hand, partnerships are really helpful for you, but we can only be a good partner if we understand your context, if we understand what you want, and if you set the pace. So I think for all the countries, no matter if you're in the university or if you're in, in the ministry, but it's very important that you as a country know where you want to go so that you can tell partners, this is our context. And these are the areas where we think we need help. And then of course, we also can say like, oh, in other, experiences, we have seen this and this are maybe areas. But I think what works really well in Ghana is that Ghana has a clear plan. They've made a strategy of where they want to achieve. So then they could also inform partners, is like, this is how we see the way forward. And where do you see your strengths on how we can collaborate? And I think it's good to find a good way of partners, international or in the same country, to engage and build good and long-term partnerships where possible. So, yeah.
I don't compromise on is that everywhere I stand, I talk about upcoming work because I'm marketing. So for those who are interested in partnerships, we've done work on hypertension, we've done work on childhood cancers, we've done work on pneumonia, we've done work in COVID-19, and this COVID-19 is a case where HTA recommendations in Ghana did not exactly translate into decision. So it's not like we got it right all the time. And one of the factors here, if you project, is the timeliness of the analysis. Decisions don't leave vacuums. So the more you are with your ICES and dealing with all your sensitivity analysis and all that, people must make decisions. So if you delay with that, then, and at the same time, if you don't do rigorous analysis, that one too is a problem. So you have to find a balance between the two. And that's some of the possible reasons why, and we are investigating this through implementation research, why it didn't translate into tangible decisions. We are looking at that in a study. Okay, so carbetocin versus oxytocin, we've done some work there. We are ongoing with diabetes, looking at novel insulins and DPP-4 inhibitor, which are type of anti-diabetic products. Cervical cancer screening is also one that is also ongoing. The man there is Dean Richmond is doing a lot of work around that. Prostate cancer is ongoing. Mental health, anemia is ongoing. Renal dialysis is something on the table. Sickle cell with hydroxyurea and screening. Diarrhea, malaria vaccine, and then another new malaria drug, artesunate-pyronidine, and then some antibiotics also. We are working with NIPH on this BIS initiative, which is also very critical, as well as working with that BICEPS for priority setting, and the Saving Consortium with University of Health and Allied Sciences for capacity building, as well as implementation research capacity building as well. We are optimizing our essential health services through these methods that I spoke about. And so by this, collaborations and partnerships are open and all are welcome into where the Black Star is sitting. Thank you.
I think Brian deserves another round of applause. But there's a way we do it. So that one, you did it yourself. Now there's the way we do it. So we'll just give him a 3 factorial. Now that we've costed and priority set, so we can do 3 claps, 2, then 1. Okay, so we'll start.
Hi, there's a question online.
Thank you. Yeah.
I brought a few copies of the Ghana strategy to prevent any issues, because there are few. The responsibility of sharing is left for them, so that if you don't get, you can actually direct your displeasure to them and not me. So if you need copies, we have soft copies that we can share. But if you want a hard copy, you can just pick one. Thank you.
Thank you very much. So there was a question here around capacity, and there's something we want to introduce for a minute, and then we close. I know we are all tired. Before this, we will present this again. Just before this. Yeah, so we realize that, in as much as we say we do not have sufficient capacity as Africans, there's John, but John is in Canada. There's me who is in Kenya. There's someone else somewhere else. But we're not sort of, together, and there's no way we can build capacity from within ourselves. So we thought hard and came up with this thing we are calling Africa Health Economics Study Group. Okay, so the Africa Health Economics Study Group is a study group housed within so it's a study group housed within the Health Economics Research Unit within Cambridge Wellcome Trust. And sort of it's a platform to provide peer learning among health economists and people who need health economics skills in Africa. So we are not restricting it to purely Africans, but of course our aim is to build capacity among Africans, but leveraging on, Africans, but as well as non-Africans. And the key role here is to ensure that we have health economics capacity in the continent, and we move beyond theory. So we found that most of the classes and trainings that most health economists go through is mostly theoretical. So we are more focused on practical skills, and there are lots of group work and exercises. So like today, I don't think you'll fully live here and say, you know everything around HTA. There are lots of things that you should have gone through. There are lots of exercises and practical things that perhaps you would have gone through. But of course, we are limited by time. So we introduce these monthly skills building workshops, and it's hybrid. So you don't have to come to Kenya to do them, and it's free. So we do them every last Friday of the month. Okay, so every last Friday of the month, it's a full day event, but each day we extensively cover something. So this is our training calendar. So we started recently, so you're not very far off if you were to join us in the next one. So we started with costing, annualizing costs, and transferring costs over time in June. And the next one is coming up on the 28th of July this month. So from there on, we'll have all these, and from there we'll have other modules. At some point, we'll create a YouTube channel where we will deposit all these materials and the sessions because they are recorded for everyone's benefit. So this was the last session. Our team again took us through, but we advertise them through all these channels, so you can click the links, email us if you want to join, but we are very heavy on advertising via Twitter. So that's the Twitter handle we use, either HERU, which is Health Economics Research Unit, Kemri Wellcome Trust, or email us through this email address or the Kemri Wellcome Trust website. So you're all welcome, and hopefully you'll join us and share. Thank you.